Sinners.
Can you tell?
The holy pictures on the wall.
Okay, members, opening the meeting. Reminding members that committee meetings are held in public session and are recorded. So please be mindful of mobile phones and Blackberries because they'll interfere with the recording equipment. I understand as well that there will be a delegation from Nairobi Regional Assembly Health Committee who are obviously visiting the north this week, and I know some members had an opportunity to meet with them yesterday. I'm hoping that they're going to attend the public gallery at some point and they will be observing our meeting, and obviously they're very welcome to do so. Apologies, members. I have an apology from Jim Wells. Any other apologies? No, okay. Members, under Chair's business, firstly want to inform members that the Minister has made a written statement today announcing the publication of the revised service framework for cardiovascular health and wellbeing for Noton. I also want to importantly raise the issue again in relation to the payroll problems that have been experienced by huge numbers of health and social care staff. It would seem that the issue has not been resolved, and that staff this month are going to, as now one of the issues certainly has been resolved, and there's an indication that staff this month are not going to receive the correct pay. We had written to the Minister on the issue, and the response has been received today, and it's tabled, members, in front of you. The Minister has stated that the BSO and the trusts are working on the issues, including running additional payroll cycles and issuing emergency payments, and that somehow the issue of the NIC payments is progressing and is being resolved. However, it does go on to say that in relation to the tax code issue, that the BSO and the trusts are working with HMRC, and that the tax codes for all but 16 staff have been reviewed. I'm asking members what further action the committee would like to take, but I would suggest that we still haven't had, I suppose, an explanation of why this system month on month continues to break down, and indeed what assurances that can be given that this will not happen again, because I do think it's suffice to say that even if we're dealing with 16 staff, it's 16 staff who will be under particular and maybe quite difficult financial hardship. So it's not acceptable, I think, given the length of time that this system has been attempted to be implemented, that we continue to see these issues, and we are facing into payday tomorrow. So I think it's appropriate that we get the explanation and the assurances that we seek that this will be rectified for every member of staff in the health service. Maggie, had you?
Just two things, Chair. I attended meetings going back a few years when this whole centralisation and stuff in terms of going to be implemented, and there was difficulties flagged up then. But listening to radio driving down this morning, one of the issues raised was that one of the reasons was that the national insurance contributions had been wrongly attributed. I don't understand that, because all the national insurance contributions for the North are held on a mainframe computer in Newcastle, as far as I know. So even if somebody here claims benefit, they have to check with them to see what their contribution record is. So that would mean that there must be an error on that computer, presumably, which is then transferred across here, and it doesn't really make that much sense. So it just seemed to be like almost an excuse on the periphery. So it's just maybe that would be something that we could maybe factor into any correspondence.
Okay, Fergal, and then
I think there are a number of issues. Obviously, there is the tax coding issue, but it's clear also that there are issues around additional monies, subsistence, etc., that individual members of staff. And from what I hear, that isn't just a systems error in the sense that it's the system, but how people are inputting information into that system. So there are questions that need to be asked there. There are further issues too around the financial situation that people find themselves in, because this has been happening month on month. People are borrowing money from relatives, and it is affecting their credit rating. and that may be something that will be ongoing, particularly if people want to borrow money for extra purchases, houses, cars or whatever. So something needs to be done in relation to that. But this is causing real pain for people, and it's reflected in, from NIPSA and other unions. I think NIPSA are gathering today. This is still very much a real live issue for people, and a painful one. And while the letter from the Minister sounds as if it's all in hand, clearly from the perspective of those who are at the coalface, it isn't.
Okay, thank you, Fergal. Roy, next, and then Kieran.
It would appear to me, from listening and to all the information that is available, that there have been a range of issues that have been going wrong. I was very much struck when the Chief Executive of the Business Service Organisation didn't want to, for instance, blame the HMRC. Now, I can only assume that's because he wasn't certain if some blame came from his side as well. There's the issue of national insurance. I have also heard talk of, is there software systems failing? But I think we should be bringing some of the officials here to this committee to really concentrate the minds and get to the bottom of what's wrong and when will all the issues be put right. I have to admit, I am surprised that it keeps rumbling on and on. Yes, the HMRC tax code is probably sorted when I largely sorted, but I haven't got the satisfaction that all issues are as of yet sorted. And I would want to ensure that we get to the bottom of it and get it finalised and get some sort of normality back into the lives of the employees of the health service.
Okay, thank you, Kieran.
Yeah, Chair, I support everything that's been said, and I think the time's running out for the Minister. He must accept responsibility. The buck stops with him. If he cannot, and he has wrote the letters to the committee and he has said that things are going to be sorted out, they are not sorted out, and people is being affected enormously when we hear of people can't even afford, and it's obvious, to pay for their child minding. They're off work, etc. There's something serious wrong, and the Minister keeps telling us that it's going to be sorted. It's not going to be sorted. I suggest that it's not sorted within the month that the Minister looks at his position. If he's not able to sort it, he should look at his position. That was that. Okay,
members, we have agreement that we are going back to the department. If we are seeking representation from the department, I would suggest that we get agreement to do that within the next week. If members are in agreement with that, but certainly the indication from here is to seek the assurances that this system will be rectified and it will not happen again. And I think, again, as a note in the Minister's response, when he talks about except that the HMRC has reviewed the tax code for all affected staff except for some 16 staff at this stage, that in itself isn't even sufficient. So we need to get those assurances, and if members are comfortable, we'll proceed on that basis.
Great.
Thank you. I know that our delegation have just joined us, and I want to formally welcome you. You're very welcome to the Health Committee. I hope you find the observation useful. You're very welcome. Also, under Chairperson's business, I want to inform the members that the Assembly's 2014 Survey of Services is now underway, and it is important that all members reflect on the services provided by the Assembly Commission and respond to the survey. The closing date for the survey is the 6th of June. I want to also remind members that next Wednesday's meeting morning, the committee will be visiting the Pavilions development in Lisburn as part of our review into supported living for older people. The visit will start at 10:30 a.m. and members will return to Parliament Buildings for 12. And the committee will meet as normal then in the afternoon. Transport has also been arranged to leave Parliament Buildings at 9:45 for those who need it. Also, just members coming from, and I know some members here were at the Age NI event this morning, there was a specific request that the committee seek information on the number of applications that have been made across the different trusts for continuing health care. And I think it would be appropriate that we would write to the department and seek that breakdown per trust so that we can share that with the organisation going forward, if members are in agreement with that.
Just Chair, just to reiterate, yes, I think that's very important, and I was one of the members that was at the meeting this morning, and there was obviously a number of very serious concerns raised at that meeting in relation to senior citizens, and I think that the committee would be doing a great service if we could get answers to those problems that you have mentioned.
Agreed, Member Shin, thank you for that. Moving on to item 3, which is the draft minutes of the meeting on Wednesday the 14th of May. Which are on page 6.
Chair,
Sure.
could I raise the last item where the committee noted the letter from the Minister of Justice to myself? I think that it's gratifying to see that in the intervening period we have now received, or at least I have received, a joint letter from the Minister of Justice and the Minister of Health expressing their desire to see progress made jointly, at least by raising it in this committee. I think that it has jolted both departments to get on with the work, because the Assembly time is running out, and hopefully the contents of that letter will see the mental capacity bill enacted before the Assembly runs out.
Appreciate that, Kieran, yes, and the item, the correspondence is under correspondence today, so it's coming up formally through there as well. Members, item 4 is the review of transforming your care in older people. This is the evidence session with Professor Tinker. I want to refer members to the briefing paper, which is on page 12. Also referring members to correspondence from the Department for Social Development, providing its definition of supported living, which is on page 16. I also want to just remind members that the committee will be holding a joint evidence session with the Department of Health and the Department of Social Development on the 11th of June. And at next week's meeting, which is the 4th of June, we will be evaluating all of the evidence that we've received to date and looking and discussing possible recommendations. So I'm therefore seeking agreement now to hold that section of next week's meeting in closed session as we are preparing the report. This is the same approach, members, that we've taken to discussing the evidence on the review of waiting time. So if members are agreed with that, okay. Okay, Professor Tinker, you're very welcome. And thank you. I'll just give you a minute to gather yourself there. Obviously here on behalf of the Department of Social Science, Health and Medicine, King's College London. The normal procedure here, Professor, is that we would ask you to make a 10-minute presentation and then we'll invite comments, questions or queries from members. So I'll hand over to yourself.
Well, thank you so much. Thank you very much for asking me. I'm really very honoured to do this. You've asked me to discuss specifically best practice, particularly in relation to Europe, lessons about supported housing, where perhaps Northern Ireland might learn. And what I'm going to do is draw mainly on research which was done for the Technology Strategy Board on long-term care. And we were looking specifically at Europe, but we also had a case study of the Netherlands, and you can ask me about that and I'll refer to it. But just to say, I'm doing it on behalf of my fellow researchers, Professor Jagin, Professor Leonie Kelleher, and Eloy Ribe. So there were 4 of us involved in this specific piece of research, but I'm going to draw on other research as well. So I have produced some notes for your clerk, which was a number of headings, which I'll just go through, and I'll just have a little short introduction, and then you may want to focus on some more than others. So what I thought would be sensible for me just to say a few words about where we're starting from, so we all agree. Secondly, what do we know? Thirdly, what can we learn from Europe? Fourthly, some of the findings from the main study and from the Netherlands. What issues, the wider issues, come out of the research? And then a note of caution about drawing conclusions from the Netherlands. We have done that, but some reasons why perhaps it might be advisable to have some hesitancy about it. So if I can just start by saying, starting from where we are, and this will be all very, very familiar to you, that the numbers of old people are going to increase very dramatically, particularly for very old people, whereas I'm sure you know, in Northern Ireland, they're going to double. I'm talking about people 85 plus. are going to double, almost double, by 2025. So not only have we got more old people, but we've got more very old people. And specifically, this will not just mean need for more services, particularly housing, but it does mean there'll be a drop of people of working age to provide those services. But I suppose the most challenging thing that we've all got to face all over the world is the percentage of pensioners who are going to have dementia. And that will be about 1 in 5 of people 85 and over. And that is, if you just think about this room, how many of us are going to land up with dementia? It's a pretty frightening thought. So I think that's the main thing that we have to bear in mind. Now, what do we know? I'll just say something about that, and then we can go on to what we can learn from elsewhere. I think the first thing we know from research abroad, particularly from the EU and the OECD, is that housing, which is one of the main foci of your committee, is increasingly recognised as being the key ingredient, if not the only one, but a key ingredient in well-being. It isn't just health, which we tend to think about, but it is housing as well. The second thing is there's a growth in solitary living, and when you're planning supported housing, I think we all have to be aware of that. It's not just people are surviving more into old age, often it will be a spouse, but it's people are choosing to live alone. They may be older people themselves, more divorce, people are divorcing much more in old age, but also an increase in solitary living in middle age. So whoever's involved with housing later on is going to be faced with more and more people who are living alone. And that's not necessarily a bad thing, because living alone doesn't necessarily mean that you're going to be lonely. The third thing is growing evidence, and we've known this for a long time, and a lot of my own research, which I did when I was in the Department of the Environment and subsequently as an academic, is that people want to remain in a home of their own. Now, we in our research are not dismissing institutional care. We say, in fact, there is a demand for it and a case for it, but what we're saying is that for people to stay in their own home, and we can unpack this later about what exactly we mean, but growing evidence that people want to remain in a home of their own and not in an institution, although that may have to come afterwards. The third thing is that housing is increasingly being bound up with the environment. We're not just talking specifically about the bricks and mortar of housing, we're talking about the environment. The work that I did for World Health Organization on age-friendly cities showed that. And it's often the little things in the environment that you, when you're looking at supported housing, need to link in with, such as, I mean, very mundane, the need for loos that older people said to us. A work that we're doing on a big new grant I'm doing with the University of Edinburgh, which is on mobility, mood and place. One of the ingredients of that, which is quite novel, is called co-design, where groups of architectural students, so we're catching them early, are working with older people to co-design housing. And they've done the first part of this in Manchester, where architects and older people work together to think, now what is the sensible thing to do about this area? So it's the link with housing and the environment. And the final thing, what do we know, is a shortage of housing. It's a mundane thing to say, but maybe we can discuss how we can get over that. So those are the four ingredients that I think we need to think about, where we are and what we know. And so learning from Europe, I don't know whether you want to start with that or whether you want me to say anything by way of introduction.
Yeah, go ahead.
Okay.
Yeah.
Well, the context of what we did when we looked at Europe, and I have to say the research is based on evaluated schemes. You can read about all sorts of things. People write into the press, journals and so on, and say, well, this fantastic scheme, it's a pilot or whatever, and you don't know whether it's really good or not. So in Europe, with the exception of the Netherlands, where we looked at some pilot studies, we are looking at evaluated schemes, and that's really a word of caution. The people are very keen to show what they're doing, particularly, I think, in supported housing. This is what we're doing, it's fantastic. But we were looking at schemes that had been evaluated, whether it was costings, views of older people, or staff. So our starting point in this was that we realised that there were things for the context. I've mentioned growing numbers of very older people, we knew that. But we also realised increased prevalence of long-term conditions. If you survive into old age, you are likely to have some measure of disability. And we don't know why women, although they live longer, are going to be more disabled in old age than men. We just don't know that reason, but they are. Rising expectations, we all expect more. More older people in employment, I'm an example of that. More older people, some people will choose to retire in their 50s or 60s, but many older people will want or have to, because of income, work in employment. And so that's a lesson for us as well. The numbers in institutions and costs, we all know that that's got a knock-on effect. We know there's very poor care in institutions. We know there are financial constraints. And we know the key role of informal carers and complexities of funding. So that's kind of the background. Well, how are we going to crack this problem, which is really the heart of what I imagine we want to discuss? And the first thing I said, and perhaps we can have discussion on that now, the lessons that we learnt from Europe, the most important one is putting older people at the heart of provision. Now, I don't know if you would like to comment on that or to ask questions.
We can probably come back to that, yeah, if members want to reflect on that when you're finished.
You want me to?
No, you go on with your presentation, if you're happy enough, and then we'll just come back.
Absolutely. Putting older people at the heart of services, it's not just lip service. We are all very, very different. Men and women are different, black and ethnic minorities. We shouldn't generalise about over 65s or over 70s or very old people. We are all very, very different. And when we did our work in London on age-friendly cities, we found that older people knew very much what they wanted. They knew and they wanted to be involved in the design of the housing. They wanted to be involved in where it was placed, whether it was a one-bedroom flat or a two-bedroom flat or so on. And part of this is the scenario, the technical term is reablement, which is starting with older people. What advantages, what skills have they got? How can we use them? How can we involve them? So I would say that let's start with older people and let's get them involved. For example, I chaired the Technology Strategy Board work which was funded on the Design Council. And there were all sorts of, now this was not evaluated, but it's just, to spark things off, where older people are actually highly involved. For example, there was a cooking club in a local area where older people were teaching younger people. There was another one where older men felt in a neighbourhood that they were not listened to, and they set up a scheme where they actually worked together to do all sorts of things. Another one is where older people share a home with a younger person. They have a say in who comes to stay with them. We could talk more about these sorts of schemes later, where the older person can choose, through a properly vetted scheme, to have someone live with them for, particularly an intern, where they would have there'd be very little rent, no rent, and in return for the person staying with them, saying, I will guarantee I will sleep there 7 days a week, I will give a little bit of help. So there's all sorts of things which I think we need to put older people right at the heart. And before schemes are designed, in fact, in research now, there are some researchers who will say, as disabled people do, nothing with us, nothing for us but with us. So I think always, and it's a hard lesson for some of us researchers, start with the older people. So I don't know if you agree with that or if you've got examples.
Okay, do you want to continue on?
It's entirely up to you. I don't want to talk.
Normally,
all the time.
we'll just finish off.
Okay,
finish
fine.
yours, and then we'll come back.
Well, the second lesson is the importance and the key role of housing, and this fits in with your Northern Ireland positive ageing strategy, your objective 3.2, which is being at home and staying in a home is incredibly important because you're familiar with it, a role in prevention such as prevention of falls and so on. and in particular the key role of adaptations, which I know you stress as well. So if you turn to ways in which older people can stay in their own homes, firstly, we do need new build. There's no doubt about it, there is new build, but of course it's expensive, and ideally to lifetime design so that it's there from day one. And of course, if you design for lifetime, you're designing for children, pregnant women, people with buggies, people who happen to break their leg and so on for a short time. So new build. I don't know if you've seen recently, it was ironical, I thought, when I was preparing this, in the Sunday Times this last week, on the back of an article which says, "After the bombs comes the buzz of Belfast," which I was attracted to as I was coming here. It was a fascinating article. Home sweet home, shed, all mod cons for £30,000. Now, you may think this is a jocular thing to say, but it may be that if you provide something which is a very inexpensive pod, which you can provide and put together, maybe for younger people, then that will also help older people as well. Or indeed, it might be something, if you have a group of these, that's possible. I mean, maybe that's at the ridiculous end of the scale. But new build, I don't think we should rule out. The second way is home modifications. Sadly, money is often being withdrawn for that, but there's a very clear research that it's cost-effective to provide modifications, aids, adaptations. Now, there are one or two schemes developing in the UK which have not been evaluated, which are about people having able to, this can be for a doctor, a carer, someone can phone in to a central point and get something modified, a loo change, grab rails, that very day. And that is also the case in the Netherlands. Once they've been assessed that very day to prevent someone moving. Now, I think those sorts of schemes need evaluating, but it sounds as if it's a good idea to have that sort of thing. And I think handy person schemes, which we've got a lot of, well evaluated. Now, this is in the UK, where somebody can come in and obviously properly supervise, provide some sort of scheme where they will do something which is quite small to the home, but it may be larger. They may enable someone to get a grant and then help with all the costs, the things that will come from the firms, all the tenders, evaluate them, make sure the work's done properly, and then make sure the person's safe back in their home. So I think the ways of people literally staying in their own home, we can learn a lot. Sharing a home with a family, now you might well think of this, and you may not think of this as being supported housing, but it is a way of someone staying in their own home. It can be the family moving in with the older person if the older person's home is too big, and this is being encouraged, of course, with the bedroom tax in the UK. Think about that, an older person moving in, but think of the reverse, where the person who is the family builds a granny flat. Now, this was actually my PhD. Granny flats are actually very cost effective and are a good way. I don't know if any of you have got experience of granny flats, but it can be very helpful that the older person can give help to the younger person can also, it can be a reverse one. It's not particularly good in the public sector, because what happens when granny dies? Do you move another granny in? Actually, it did work quite well in the social housing schemes I looked at. What happens if the family move? But, you know, granny flats is one way of enabling, say, an older person with a large property to move in with a family, and you saved on that kind of housing. Or fostering. This is developing in the UK, but it's also developing across Europe. Shared lives, adult placements, rather is done for children. Provided it's properly vetted, then that is another way, particularly of saving accommodation, where an older person may give up their home and move in with a family, but clearly it's got to be very carefully vetted. Do you want me to carry on with
Yeah,
other
sure.
schemes?
Yeah.
Okay. Well, one of the things I think from Europe is very interesting that we hardly do here at all. It's called co-housing. And there are, it's most widely practiced in Denmark. There are 350 schemes there. This is where a group of older people, it started with younger people, but now it's older people and some mixed communities. It's where a group of people come together, 10, 20, 30, and they decide that they're going to live together in old age. They have their separate apartment, but they have some shared facilities, such as perhaps they may have a club, they may have a laundry room. And this has been very well evaluated. It's particularly in Scandinavia, in the Netherlands, and there's now a group just started in North London where a group of older women have decided, well, why not? If people are going to save accommodation, they can then group together. Now, the evaluation in the Netherlands showed that a scheme's got to be very clear to cope with conflicts, because this did happen. People have got to have a sense of responsibility, and there were some conflicts. But, you know, co-housing is something which I think we might possibly want to foster. Home sharing I've mentioned, where an older person shares their home. And one of my own students actually did this, lived in a very big house, lovely, lovely house, which he couldn't afford to have rented, but in return had a very close link with the older person, and she went far beyond what she was bound to do, which is sleeping there and giving a little bit of help, not personal care like bathing. So I think, you know, this is another thing, if you're thinking about supported housing, kind of think widely. And then there's the specialist housing. Do you want me to pause here to see if we've got questions?
No, you go ahead if you're comfortable enough.
You don't want to discuss co-housing or any of the other options, no?
We'll come back to the individual
Fine.
things, yeah.
Okay. Well, if we move on to specialist housing, which it's interesting, if people come from abroad to the UK, the thing they always want to see is sheltered or very sheltered housing. I think it's completely bizarre, given that less than 10% of people live in it, but it's the one thing people from abroad always want to see. Now, I'm sure you're familiar with sheltered housing. And I think one of the Commissioner for Older People for Northern Ireland, from whom you heard evidence, I've done my homework, you see, she said there's confusion about terminology. I suggest we don't get hung up on terminology. It's called assisted living, all sorts of things. I would prefer to talk about sheltered housing and extra care housing. So if we think about sheltered housing first, which was the best thing since sliced bread in the 1960s, developed in the UK, and although I say we're learning from Europe, there are some things where England and Wales have been very, very good at, and that is sheltered housing. In the past, these schemes developed groups of people, bungalows, living together in bungalows or flats, with communal facilities and a warden. Everybody thought they were wonderful, but they aren't. They are no good for frail older people. Why would you move to one of these if, in fact, you could stay in your own home? Because they don't offer you very much, apart from being grouped with other old people. And so what was discovered, and I did the research on it, was most schemes, whether they were social housing or private, were difficult to let. People could not believe it. How could a scheme like this be difficult to let? So what seems more promising is where you add on to these schemes and either call them very sheltered or extra care housing, which is where you provide, say, 1 meal a day, you have 24-hour care, you have extra communal facilities, you have these kinds of things where, in fact, a frail older person can be supported quite well. But amazingly, some of these are difficult to let too. So research which I did was called remodelling, and I've provided your clerk with the summary of this. What we looked at in research, and this may or may not resonance with you, is we looked at sheltered housing, extra care housing, and residential care homes, which are very unpopular, how they could be remodelled to provide extra care housing. How could all of these, particularly the residential care homes, how could they be remodelled? Now, what we found was that, A, it's very difficult to do if you've got a listed building. B, in nearly every scheme, they ran up against problems, quite often asbestos problems. C, it's not necessarily cheaper to remodel than to provide from scratch. But of course, you don't want to knock down all these schemes mostly. But extra care housing, subsequent research by colleagues Anne Netton and colleagues at the University of Kent have shown that extra care housing is one of the ways forward, and it's certainly one of the things which the government is giving money for, because it does seem to provide at least care and ways in which people can join together. Subsequent research, which has been done by Richard Best and Jeremy Porteous, suggests it may not actually be economic to have all the range of communal facilities, but I would suggest that extra care housing is something which you may, I'm sure you've got these schemes, but it is a very positive way forward. The more trendy thing, of course, is retirement villages, which they've got a lot of in Australia and the States. Caution about these, particularly where they're private. In the States, they've found that their terms, when people come in, people can actually be turned out when they become frail. Some have gone bankrupt. We've had them in England for a long time, such as licensed victuallers. Imagine it, spending the rest of your life with fellow pub owners, but very little evaluation. There are two famous ones that have been evaluated in the UK, in York, the one, and Berryhill in the Midlands. So retirement communities might be popular, and research has shown that. So that's a possibility. Now, here, again, we've got an example from the Netherlands where they have got villages, but they've been very unusual in that, in particular, in one, for example, they've got people, it's called a care cooperative village, where they've pooled out a lot of the facilities, such as they have one care coordinator for everybody in the little village. They pool their personal budgets. The gardens are done by workers in that area who are in sheltered employment, so it's giving employment to people. They use volunteers, so there's a lot of social interaction. They loan out motorised scooters. So a care cooperative village, again, is a possibility. Maybe you've already got an existing village where you can do this, but it's bringing in resources, it's bringing in volunteers, it's bringing in people who need employment. Do you want me to talk about some really radical alternatives, which I mentioned here, which is, you want to go on to the cruise ships and the hotels?
Yeah.
Yes?
We like radical.
You do? You like these? Okay. Well, you probably read the couple who went to a travel lodge and stayed 22 years. Did you read about them? Because they found they had everything in the travel lodge that they wanted pretty well. Actually, they did move out after 22 years. That's not been evaluated, and it's a one-off. But more seriously, cruise ships. And there's been a well-evaluated evaluation by a geriatrician, a cost-benefit analysis. If you've got a lot of money, it's very cost-effective to go on a cruise because you have all the facilities there. You're not far from a loo at any time. You've got fantastic medical backup. You've got, and when you have, you're going to be very popular when your grandchildren and your children want to visit because they've got all the facilities. So, I mean, I joke, but I have a friend who sadly died now, who had terminal cancer. And one of the things she did at the end was actually she went on a cruise, and they are much cheaper now because everything was at hand. So we're thinking not just about very poor, but we need to think about people with a bit of money. And now, of course, you can spend all your money when you get your pension. Maybe we shouldn't go down that route, though. But anyway, so there are radical options. In the main, as I say, they are for people. Of course, people in the 1930s did go to boarding houses on the south coast of England. And that's where they lived. who's to say that, you sell your home, you go to a hotel? Would you like that?
No thanks.
You think you'd like to live in a hotel for the rest of your life?
That's just saying there.
Shall we move on to
Yeah,
technology? No? No response from anybody who wants to live on a cruise or a hotel? Right, technology. Well, again, I think we're incredibly hung up on words. Nearly every time I look at anything to do with technology, it's called something different. It's telecare or telehealth or whatever. So I don't think we should get hung up on that. But I do think the use of technology in your supported housing is very important. So telecare is really where you're providing something like simple personal alarms, like a pendant that people press, right through to smart homes, which I'll develop in a moment. But they can do a whole lot of things, including helping people to remind them to take their medication. They can press a button, it can alert someone. So there's that. Telehealth, I think, if you can have this in someone's home, telehealth is delivering health care at a distance. It's where you assume that there's a health professional at either end of the technology. And so you can have a carer in your home, and you could say, put your hand under the under a camera, and someone at a distance can make some observation about that. Vital signs of monitoring. I'm sure you're going to have this installed in supported housing in the future, where somebody doesn't have to go and have their heart monitored, blood glucose, weight, and so on. It can all be done at a distance. I'm in a longitudinal study, and I wore one of these for 7 days, and everything that I did went through to some central point. Incredibly useful, that sort of thing. So I'm sure that's got to be built into things in the future. And you've got one, I gather, an extensive telehealth programme supported by the Centre for Connected Health and Social Care. I gather, I don't know an awful lot about it, but I know you have. Now, great potential, but a word of warning about technology and the hype. The findings of the only randomised controlled trial of telehealth in the world was paid for by the Department of Health in England. It's called the Whole Systems Demonstrator. And it was with 6,000 people with certain conditions in Kent, Cornwall and Newham. And it was about transmission of data between patients and professionals. And at Christmas, the Christmas before, some early findings came out about lowering mortality and lowering emergency admission rates, which was fine as far as it went, but subsequently caution. If you look at that study, the response rate was not particularly high. The sample included people very low risk and so on. So I think, one's got to be aware of it. But the thing that's come out of all research on technology is the value of simple gadgets. Make it simple. We did a study with engineering students, and we asked a group, this is again working with older people, back to my first message, which is we got a group of engineering students to get together with a group of older people, and we had already said to the older people, what are the major problems you have? And they said, walking up and down stairs. So the older people worked with the engineering students to devise a very, very simple ratchet of a rod, which it ratchets up the stairs. And the things they said about it that they loved was it was wood, shiny wood, it wasn't plastic, which a lot of things are, and it was very simple. I think greater use of mobile phones is the way forward. Now, you may or may not have noticed, I carry my phone, which of course is switched off, everywhere, everywhere. And I do this for a reason, because my children have told me you need to be accessible at all times. We need to contact you. You may need to contact me. I carry my phone the whole time. I think mobile phones have enormous impact on people. I don't know if you feel this, and of course smart tablets and so on. But the final thing about technology, I think, is, no, it's not the final thing. I do think there are ethical issues to do with surveillance. How would you feel if you were in a home and you got all this equipment round you and you knew that someone was monitoring you? Somebody could see you, as indeed parents now can see the child manager or the nanny looking after the child 24 hours a day. How would you feel about that? Well, but the internet is extremely important. Now, here is an example of older people working with internet companies, and here again potential for investment in Alamere, where they got together a group of older people and internet companies, and they invested in high-speed broadband network, which enabled older people to do what they wanted to do, which was to join in exercise classes, to be involved in art, music, theatre, and so on. And the evaluation reported not just increased social contact, but stimulated economic growth. So I have given the full reports of the research to your clerk. You may want to look at that. It's an interesting example of an area. It's slightly beyond your supported housing, but it's a good lesson where you can stimulate the economy and involve older people. And then there's finally, on technology, smart homes, where you link everything up in one home, where you have the whole lot. So again, I pause. You want to ask anything on technology?
Okay, at this point, because I'm conscious that you have given us quite a range of themes and information, at this point, do members want to ask any questions on what you've heard specifically? There's a number of names. I think Kieran had indicated first.
Chair, I mean, thank you very much for your presentation. It's been very interesting. In fact, you've probably answered all the questions. The main one was, how can older people have an effective say in what their requirements are? And I think you've touched on that. And what steps can be taken to better address social isolation within such provisions?
I think it's difficult to involve older people. Well, let's make no bones about it. You can go to the conventional, you can go to the groups, the well-known suspects, people who always will say, I speak up on behalf of older people. It's very, very difficult to get hold of. This is in research as well. People who are at home, who are housebound, I think one has to make very deliberate attempts to get hold of the people for whom there is no voice at the moment. And it is a problem. There is a problem of social isolation. And people, I don't know if you know, the most isolated people in other research are in southern Europe, where they have got the highest rate of living with families. The families go out, they come home, they do things. And the lowest rate of loneliness and social isolation is in Scandinavia, where they've got the highest rate of solitary living. So, you know, one shouldn't make assumptions.
And are there any examples of best practice in terms of a shift of resources from acute services to support the emphasis that is now being placed onto community services? Do you have any evidence?
Most countries in Western Europe, because of welfare cuts, are doing that. One way they're doing it is by giving personal budgets. Now, I don't know if you want me to talk about them, because here is the word of caution, because this is slightly off what you're saying, but to give money to people individually rather than, say, hospitals. Personal budgets, research is very, very mixed about it. In the Netherlands, where they've had them for a long time, they have now stopped them completely for new applicants, partly because of cost, partly because of abuse. They were being abused. So I think a word of caution about actually giving the money to people individually. Fine in theory, but if you've got the money, how do you choose yourself? Do you vet does the older person vet the person who's going to provide the service for you? Do they check on references? It's difficult. So it's part of the shift.
Okay, thanks, Chair.
Thank you. I have Mickey next.
Yeah, thanks very much for a very interesting presentation. And talking about, and Kieran alluded to it, having older people at the centre of making policy and legislation that affects them. I mean, we advocated for a long time for an older persons commissioner, and really I think they should be very involved in the issues that affect older people. Also, this week we have tomorrow and Friday the Pensioners Parliament. The 8 sector platform, AGNI, here are very, very effective in the role that they do in advocating for older people, and I think that's very important. In terms of the housing, many years ago the Housing Executive here used to build OPDs, old persons dwellings, but they got subsidies to do that. When those subsidies stopped, they then became single persons dwellings. There were 1 or 2 bedroom bungalows, but there weren't that many of them. And initially they were being retained for older people to move into, obviously, and younger people wouldn't have been made available. But in terms of lifelong housing, in my own constituency, some of the housing associations have built fairly limited numbers of lifelong houses. But you can see the benefits: wider doors, ramps, recyclable water, panels in the ceiling where in the future if a person needed a floor-to-ceiling lift, it's relatively straightforward to install one. They don't have to rip ceilings out and all of that kind of thing. So it's a bit of foresight and forethought and forward planning. You mentioned granny flats. I mean, one of the issues that I've come across where people have applied for planning permission, here it seems to be quite difficult for people to get planning permission in many instances, so I think that's something that could be looked at because they can be effective. In terms of social isolation, and you mentioned Sweden particularly, where a lot of people live alone, but social isolation isn't a problem. Maybe we as a race here are maybe more gregarious, so, you know, an extended family, so maybe that's something again that we could look at. I sit in the DSD committee which deals with housing and benefits, etc. And I suppose one of the big issues for older people is the amount of benefit or money that they have to live on, because here and in Britain we have one of the meanest pension schemes in the developed world. You get paid basically at a flat rate. You contribute for many years and you get very little out of it, obviously depending on how long you live. So maybe that's an issue that does affect people. But it seems to me that with Health and DSD, Department of Social Development, there isn't enough interconnection on issues that affect older people in particular, and I think that's something that needs to be looked at. And I think that's something that both committees and indeed the Assembly should be looking at, much more interaction between departments, because a lot of the issues that affect older people are very much interconnected with the different departments that deal with it. I was interested in your radical stuff around cruises, and that problem I might have with my luck, I'd probably end up on a cruise ship with retired DUP members.
Very few of them about.
Well,
It's going to be more. It's the future.
that was just a final thought, but thanks very much.
Can I respond to that?
Sure.
Old People's Parliament, extremely important, very important. The housing about the number of bedrooms is an interesting one, because the reason why many schemes have become difficult to let is because there was only 1 bedroom, and certainly 2 bedrooms is the way forward, because couples may, for all sorts of reasons, want to live separately, and a carer and so on. But interestingly, at the last Housing Lynn conference before Christmas in London, there's maybe a reversion to bed-sitters for people with dementia. I mean, we can mention dementia specifically at the end, but people with dementia, it may be sensible to provide a bed-sitter. So, you know, 1-bedroom flats or 2-bedroom may be the way forward. Granny flats, Planning Permission has now in England been slightly modified. So, yes, interconnected is extremely important. Government departments speak to each other, absolutely. And pool budgets, all sorts of things like that can do that. A lot of it is personalities. Do the people in health and so on get on well with housing? A lot of it's that.
Okay, thank you. I have Pam next.
Thank you, Chair, and thank you very much, Professor Tinker. Really enjoying this evidence session. Fascinating. Just on the co-housing issue, with people living independently in their own accommodation as a group, and you'd mentioned, you know, groups of 10, 20, 30. It seems a very large number of people. Can you tell us some more about how that works? I mean, this is based on living in their own homes.
Well, what they normally do will be buy a large building. It might be an ex-hotel, it might be a big, say, Victorian house, or they might build afresh. I think the one in North London, this group of older, I think they're building afresh, but I'm not sure. But it is possible. You can get, in the Netherlands, they have blocks of apartments where and in fact some of them actually do cook together. And I think, the one I'm thinking about, I think there are 30 people, both men and women, living together in apartments. But they do share a lot of things. They do share the cooking, they share the laundry and so on. So you can have it of all sorts of different sizes. It's an interesting concept.
Yeah, it's a very interesting concept, and
Men and women live in
that's not provided by local council, or is it provided by...
It can be subsidised, but quite often it's provided by people chipping in their own money. But there can be subsidised schemes.
It's very interesting, because I think we're always looking for ways in which the state will provide.
Yes.
But actually, a lot of what you have in your presentation is kind of more common sense.
Of course.
Kind of empowering people to look at what they can actually do themselves.
Yes.
and decide, how they want to live
Right.
into the future, as opposed to... I think you did mention, I hope I got this right, did you say residential care homes in England were very unpopular?
Yes,
Yes.
mostly residential.
Yeah.
But you're right, a lot of what I said is common sense,
Yeah.
and a lot of things in life are common sense.
Yeah.
I mean, I think the other thing we haven't touched on, if I might mention, is that we can learn, particularly in the Netherlands, is dementia care, where they've got some very interesting, and this is part of the village community, where there are groups of people who live together, some of them demented, the demented people may live together. Others are according to their particular interests. So you've got people who are maybe ex-civil servants or people who are interested in art and so on living together in a community, but separate. But there's another village there where they're even more creative, where older people are living together, and I think this is subsidised, where not only do they bring volunteers in, but they get school children, 16 to 19-year-olds, they employ them in the evenings to cook the meals for the older people. So again, you're encouraging the mixture of generations, but you're also creating employment for people. So I think, the use of volunteers, the use of people coming in is another way we can learn from the Netherlands.
Fascinating. Thank you.
Okay, Pam, thank you. Fergal?
Thank you very much, Chair. I'm just thinking back to Mickey's comments there. It's clear that by the time Mickey retires, he doesn't believe he'll have united Ireland, and in fact, he might set about trying to unite the ship going round it. Yes, can I go back to the? I'm interested in the legislative platform that can drive some
Which
of this.
platform?
The legislative platform.
Legislative, yes.
And here, the absence of such legislation means that older people, can in fact be discriminated against. So what form of legislation do we need? Do we make sure that in fact people can demand that they get provision as opposed to earnestly pleading for it?
It's very difficult in housing. Certainly in health there is legislation, and that under the National Service Framework originally, and then it translated into legislation. You can't discriminate. You can't say, as we used to have in London, for example, a stroke unit will not accept you if you're over the age of pensionable age. That you can't have. There is still discrimination in employment in the UK, even though there's legislation. So I mean, you may be able to legislate, but there are ways round it. I think it's a change of attitude more than anything. I'm not sure how far you can go with legislation.
Productive ways around it?
There are what?
Productive ways around it? Productive ways.
Oh, productive ways.
Is that what you're saying, that
Yes.
there are ways around it?
I think it's a change of attitudes, that we don't treat older people as different from others, and we don't discriminate just because you're a pensioner or of a particular age or gender or anything else. But I'm not sure. Do you think you could do it by legislation?
Well, I know, for example, in England that the Equality Act brought in the Goods, Facilities and Services,
right.
which allows for people to demand or expect certain provision. And here we don't have that yet. So
Right.
therefore,
I didn't know that.
Yeah, so therefore,
Well, maybe that's one way forward. You know more about that than I do.
yeah. Just one other point, and it's down to how people are grouped, if you like. And as you said, maybe artists, but even within artists, some
Yes.
may favour music, whereas others may favour a different version. So how does the individual get a voice?
Well, it depends on...
Even when, and many of them don't have a voice, of course, because
No.
they've got dementia or whatever. So how does the individual with a voice get it heard, and how does the individual without a voice get their needs catered for?
Well, I think this was mentioned by the first question. You start with your Older People's Parliament, which we don't have, right down to an individual scheme, a local authority, people like me, research involving older people from day one. But it's not easy to get groups of older people or individuals. I mean, you can do it by research, and as a researcher I would say that, wouldn't I? That one way of getting the views of older people is actually through particularly qualitative interviews. And you may find quite unexpected things. I mean, for example, when we were doing our remodelling, we found very mixed views where older people were left in situ. In other words, they were left and the scheme was remodelled around them. And by doing the interviews, we found, yes, there was disruption, which we'd expected, but on the other hand, they absolutely loved it. They loved having electricians and all sorts, not being sexist here, all sorts of people around them. They could interact. There was something exciting going on all the time. And so, you know, people's views that we thought, oh, they're not going to like it, it's all going to be incredibly disrupted and dangerous too. When we interviewed them, it was quite the opposite. It was a buzz. They really loved it. Now, would we have found that? I don't know, without asking them individually. I don't know. But it's not easy to find out views of older people.
Okay, thank you.
Okay, and Roy?
Again, interesting to hear of evidence from elsewhere, but one of the points I'd like to pick up on was you mentioned that there was schemes in various parts of the country in terms of same-day modification for older people living within their own homes. Recently I came across a constituent who needed a raised toilet and support centre to make that a safer area, and was told it'd be 5 to 6, maybe even 10 weeks before someone would be out to assess whether this is what she needed. Can you advise of particularly good schemes, and have any of them been evaluated in terms of just how much benefit it brings to the individual and how much longer it keeps them in their own homes?
Yes, I've given evidence in the paper, which I've given to your clerk, about staying put schemes and handy persons, which have been evaluated, well evaluated, and are cost effective. The new one that I mentioned, the First Contact scheme, has not. These are developing. I mean, I've got details here of the Derbyshire one. That has not been evaluated, and this is where somebody, it can be the doctor, it can be rings up and gets that adaptation immediately. And you've got that in housing associations in the Netherlands. That's not been evaluated, but it sounds a good way forward, doesn't it? But certainly the conventional staying put, yes, very good evaluations of them.
Is there evidence in terms of how many accidents and costs to the health service have been avoided by that very speedy response?
I think there is one offhand. I think there is one about prevention of falls. I'm not sure. I can't give you chapter and
Could you
verse.
perhaps come back to us?
Yeah, of course, of course.
Thank you.
Okay, can I maybe just ask, obviously thank you as well for the presentation, and I think what is apparent, Professor, is that you can be creative with some of these models in terms of supported housing, supported living, but I was particularly interested, you're saying that don't get too hung up on definition.
Yes.
And that's the first time we're hearing that message, because consistently we found that there hasn't been a clear definition of what supported living or supported housing was, particularly from the Department of Health's point of view. And now there's been agreement that they'll look at what that is. But you talked about almost very sheltered and extra care. And I'm just wondering, flowing from that then, is there an agreed, if you like, cross-departmental, cross-agency definition of what extra care facility would be? And then how does that information on choice. Who is responsible for, if you like, for want of another word, marketing the availability? That's one of the things that we're finding, that there's a real issue about choice in the types of supported housing or supported living. So who, in your experience, in terms of maybe the European models, who's been responsible for marketing or providing that information?
Well, it depends on the provider. The Department of Health has one. Department of Communities and Local Government have, of course, had a supported housing series of grants. There is no agreement, and I'm not sure how you're ever going to get it, and particularly private providers are going to call it whatever they think will sell, aren't they? I don't know how useful it is to have one common definition. I mean, I use mine. I use sheltered housing, as I've described to you. I use extra care housing. But then some people use supported housing, assisted living. Do you think it's really important that we agree?
I suppose it's the issue of forecasting the population. We know the forecast, the elderly population. We know the statistics. We know where we're going to be in 2020. We even know some of the geographical areas where the growth will take place. So I suppose for us, for a committee, it has been very much about understanding that the whole strategic change in health is about care at home or care in the community or reablement.
Yes.
Which isn't always an option, but it's about saying then how, if we have this elderly population and growth in an ageing population, then how do we plan for that, and what are the types of models or living arrangements that we need? And I'll just give an example. We visited a facility which I think members will agree was an excellent supported living facility in Downpatrick in the last number of weeks. And what was interesting was it was people with different levels of need, including those with kind of mild to moderate dementia. But even at that, there was a number of places. It was an excellent facility and some real characters living in it as well. But there were still empty places. And so you just wonder the flow of information in terms of choice. How is that information relayed through the system that our elderly people know that there is availability in these models?
Well, maybe by asking me to talk about supported housing, I mean, you've defined it for yourself. I would include anything that you want under it, but it is difficult if you're trying to explain to someone what it is. I mean, most people know what residential care is, they know what a nursing home is, but this whole plethora, and I've described some of the options of staying at home and in some kind of more supported conventional, no, not conventional, more what used to be called sheltered housing. I think it is very, very difficult. I mean, maybe you should say what you think the definition should be.
Yeah. Well, I think, I mean, just to take you up on that, the Department has come back now and said that they are reviewing and looking at an agreed definition. Right. And I'm sure the committee will have a view to that as we move forward. But I'm just conscious of time at this point, Professor. I don't know if there's, I know that we stopped probably 3/4 of the way through your information. If there's anything you want to add at this point, we do have the information and we will obviously reflect on that and going forward. But if there's any other comments that you want to make by way of concluding remarks?
Well, I have given all the... I think the only other thing to add is I think we have got to do something about the low status of staff who care for older people. I think that's incredibly important, that lowly paid, low status, and they're the key, really, to care of older people, whether in supported housing or wherever they are. So I think that would be one of the things which I would think is probably the most important thing, that we need to change attitudes as well as training towards these people. And if they earn less than they can get in a supermarket, what does that say about us as a society? So I do think that's really important.
Okay, well listen, can I thank you very much? That has been extremely useful. Obviously the committee will reflect on all of that. I think there's been a lot of common sense included in your presentation, so I thank you for taking the time. It's certainly been of benefit to yourselves.
Thank you very much.
Thank you very much.
And if there's anything that your clerk needs to get back to me, I'm sure she will.
Appreciate that. Thank you, Professor. Okay, members, moving on to item 5, which is the evidence session on the June monitoring round and provisional outturn. There is a briefing paper in your packs from the Department at page 19 and a letter from the Minister on page 91.
It's just these,
Deja vu all over again.
You're very welcome, Catherine, Julie, Sean and Liz. Welcome, familiar to the committee, and for the format here we would ask for approximately 10-minute presentation, then we'll open it to members' comments. So, Julie, I'm not sure if it's yourself that's leading on it yet.
Thank you, Chair, for the opportunity to provide evidence to the committee today on the Department's forecast outturn for 13-14 and its participation in the June monitoring round. As we've previously reported to the committee, 13-14 was an exceptionally challenging year financially for the HSC. Indeed, this was reflected in our approach to January monitoring last year, in which bids of some 65 million were submitted in order to address the pressures we were facing at that stage. Every effort was made to address the financial challenges during the course of 13-14, while still maintaining the quality and safety of services. This included the implementation of low-impact contingency measures at trusts, examining all aspects of the Department's budgets in order to secure available savings opportunities. There was also extensive engagement with key stakeholders across the HSC and with DFP. You'll be aware that the Department fully participated in the 13-14 in-year monitoring rounds and secured additional funding of £55 million for the revenue budget. Unfortunately, despite these measures, the Department is anticipating a cash overspend of some £13 million in 13-14, which is approximately 0.29% of its budget. I'll now outline the Department's proposed approach to both the current expenditure and capital investment expenditure for June monitoring. In determining our approach to current expenditure, we have considered a range of factors, the most significant of which is the financial context for 14-15. As outlined in the briefing paper which was sent to the committee on the 29th of April, the Department faces a considerable financial challenge in 14-15, with some £160 million of additional resources estimated to be required in order to balance the books. Of this £160 million, £115 million of the deficit is rolling forward from 13-14. Now, much of that deficit was dealt with during 13-14 through non-recurrent measures and including additional allocations from the in-year monitoring rounds and the managed slippage and deferral of expenditure. The remaining deficit for 14-15 relates to new service developments, which are essential to sustain current policies and provide new, cost-effective therapies. Together with cost pressures such as pay and demographic changes, these total some £305 million in 14-15. They are offset by £90 million of executive funding and £170 million of further savings, and that's set out in the briefing paper as well. This group of factors represents an additional net pressure of £55 million. Financial deficits are projected in all 5 integrated trusts in 14-15 due to frontline service pressures in a range of areas. The Department, the HSCB and the Trust have been working closely to identify opportunities for delivering both cash releasing and productivity improvements, totalling some £170 million in 14-15. These are in addition to the £490 million of savings already achieved in the 3 years to 13-14. Unfortunately, despite the additional executive funding of £90 million and the demanding savings plans of £170 million, we still have a funding gap of £160 million, which means we are submitting a significant number of bids in the June monitoring round. You will see that these bids, which again are set out in the June monitoring briefing paper, total some £160 million and are primarily directed towards delivering a range of critical frontline health and social care services for patients and clients in Northern Ireland. For example, there are substantial bids in relation to unscheduled care and emergency admissions, elective care and specialist services such as drugs, cath labs and cancer services. We are also bidding for TYC transitional funding to enable progress in the implementation of transformation and for clinical negligence pressures which are inescapable. The bids will be used to ensure that key services can continue to be provided to some of the most vulnerable people in our society, including children, the elderly and mental health and learning disability clients. In short, they are essential to sustain the long-established policies and principles of health and social care in Northern Ireland, where health care is predominantly free at the point of use and not limited by predefined exclusion of various therapies. Turning to capital expenditure, DFP has advised that capital expenditure bids in this monitoring round must be for projects that can be fully spent in 14-15 and they must not carry a tail into 15-16. We have reviewed the planned capital expenditure for 14-15 and, in line with routine processes, have already reallocated any identified slippages and projects to other priority areas which can spend in year, including general capital, ICT and equipment. In that context, and given the significant constraint to ensure that there are no tails in the projects into 15-16, no capital bids are being submitted in June monitoring. In conclusion, the scale of the projected funding deficit in 14-15, after additional funding and the delivery of significant savings, clearly indicates that it is not possible to fund a number of critical service pressures from within existing budget allocations. Our proposed bids will help ensure that there is no detrimental impact on frontline health and social care services, and we would therefore strongly recommend that these bids are considered favourably by both the Committee and the Executive. We are happy to take questions from members on any issues.
Okay, Julie, thank you for that. Just, I suppose, in relation to the overall context, conscious of the Executive's agreement around additional in-year flexibilities in terms of health, which is very welcome, but that it had been stipulated that current expenditure bids should not be tabled by health unless they were of major and unforeseeable circumstances. Can you assure the committee that of the 160 million bid going forward, that all of those are major or unforeseeable?
Absolutely, and you're quite correct in your analysis of the approach to monitoring rounds within the department. They are certainly major. I think that the size of them in themselves point that out. Equally, in terms of unforeseen, they reflect changes. They're unforeseen from the setting of the budget in 2010 and goes back to that period. And effectively, as the committee is well aware, we have been making bids through and monitoring rounds through the last couple of years, and most notably, I guess, in January monitoring when we made bids of 65 million. Working forward now into 14-15, this is just building on, and a lot of the bids, I'm sure the committee will have a degree of familiarity with them because we have discussed them before in previous monitoring rounds.
And I'm just conscious on that similar vein, and I do appreciate that we have had prioritisation given to the bids this time. We've had many a discussion around that, and they have been categorised. But I'm thinking about things like the transitional funding for Transforming Your Care, which all of a sudden is categorised here as a C, which ultimately means these pressures are not contractually committed and could therefore be scaled back to within available resources. And, everything that we discuss and are informed of in relation to Transforming Your Care is that this is the great hope in terms of the shift left and everything that will bring. So how can we justify that? How can we justify that the transitional funding, which was a 3-year programme, which was indicated at 70 million, has now become a category C?
I think the committee would recognise that all of our bids are of high priority, and you're absolutely right. We have had discussions about the difficulties of prioritising these bids in the past. The only reason why the ones at the bottom of categorised C is because effectively, because they're not contractually committed, they could in theory be stopped should resources not be made available. A lot of the ones that are above that relate to expenditure which will be incurred and which will have to be financed. That's the only distinction between them, but in both the opinion of the department and I would suspect the opinion of the committee, each and every one of these bids is of a high priority. And it is very, very difficult to pull one bid out above another. The only reason why they're at the bottom is because they can be scaled back if necessary in order to live within the budget that we have. That does not apply to a lot of the other bids that are higher up the table, but it in no way reflects any diminution of the priority of transforming your care.
I remain to be convinced on that, Julie, because whilst you could argue that TYC isn't contractually committed, it's been mandated and endorsed and is the framework in which we are about to deliver a new health and social care service. So that would suggest to me that we need to get the framework right, we need to get the transitional funding right, and a lot of these other issues will flow from that. And that therefore it should be further up the pecking order.
Yeah, and I guess when you look at the other issues, when you look at the demands around children's services, around domiciliary care, around special services, around unscheduled care, they're all presenting, if you like, within the trusts. Every single one of these bids, I think, is exceptionally compelling in terms of the costs and the pressures that are applying within the trusts as we speak. And therefore it is very difficult to say that one is more important than another. Ultimately, the executive will decide what is the priority of these bids. We will put the bids into the executive system and it will be up to them to decide, and they are entitled to move bids around and could move bids around in terms of what they agree to fund, if any of these bids. So that's the ultimate deciding factor.
I think as well, Julie, we've had this conversation with the department on a number of occasions. Each department has their priorities, or should have their list of priorities. And maybe could I just ask then, out of the 70 million that was suggested for transition, how much has actually been secured?
28 million, 19 million 2 years ago and 9 million last year. So
there is a severe shortfall.
At the moment, the bid that we have on the table is 21 million for 14-15, and some of that, obviously, what we got in 13-14 was a lot less than what we bid for. We bid originally at 28 million, and we received 9. So 21 million reflects what we would believe is necessary in the 14-15 year, and we may need to bid again within 15-16.
But out of a projected spend of 70 million over a 3-year period, we've secured 28.
That's right.
And we're now saying that this bid for 21 is priority C as opposed to the top of the list. Is that given an indication that transforming your care is at risk?
Could I maybe pick that on, because I just think it's really important to emphasise to the committee it's absolutely not any diminution in terms of the priority of transforming your care. It is a major and key priority for the Minister, and it's absolutely upfront. It's Julie saying about the distinction there. It's actually just making that legal distinction, because there are contractual commitments which expenditure is already incurred for in other areas, and so it's simply not possible to stop those. Strategically, you would argue that it's not possible to slow down transforming your care in terms of the interests of delivering high quality and safe and effective services. That's what the whole programme is about. So I think it's just really important to emphasise that. And taking your point about the 70 million and the original profile, and we had said that as plans are rolled out, there's a possibility that the profile changes, and that's part of what you're saying here. It's not saying that the 70 million is not required, and overall the Transforming Your Care programme is a 3 to 5 year programme, was always intended to be, although we were looking at the projections over the 3-year budget period at that point in time. But it's absolutely critical, and right across the service actions are being taken to implement it, and that's what the purpose of this bid and the various categories of the bid, to ensure that that implementation can continue to progress. But that's one of the real difficulties, because if we don't get the funding for Transforming Your Care, and faced with all of the pressures across the budget, it will impact on the progress
Which
of
would seem to suggest that you prioritise it over a number of other things, in my view. But Fergal, is it on this issue?
It is just specific. So where does it leave transforming your care now? If, I mean, as I see it, last year you looked for 28 million in June and you got 9.4. In January you got 7, although that may have been for a 3-month. Did you not get 7?
In January, we got a total of £30 million from in-ear monitoring, and none of that went to transforming your care. No, it went to
Clinical negligence.
No, it went to hold on a moment. Children's services, safety and quality of services, unscheduled care, domiciliary care, and elective care at the time.
So you're sitting. I'm just trying to work out the maths here. I thought you had got 7.
We got 9. You're absolutely right. The 9 in June monitoring went to transforming your care, and that was added to the 19 that we got to the previous year, makes 28 in total. That's the money that has gone into transforming your care to date. And then we want to build on that with another £21 million bid.
Chances of you getting the 21 million are what?
Well, we put our bids into the DFP system and we see what comes out the other side. That will be dependent on the executive.
But furthering this point about the prioritisation, and given that the response you got last year was 9.4 over 28, your expectation this year will be certainly less.
Well, I guess that all of these bids, or I'll come back to the same point, all of these bids are high priority bids, and the only distinction between them is that we can pull some of the expenditure down on transforming your care. We wait to see what the executive will decide in terms of both money and prioritisation of where those resources go to, and we'll have to reflect then after that as to what happens next.
Yeah, but you can't make the decisions around implementation and transformation if you haven't got the funds.
In the same way as yes, we have to live within the resources we've got. You're absolutely right.
So where does the transforming your care plan stand against that doubt or vulnerability around funding?
Well, in terms of any of these areas, Fergal, I'm not trying to be awkward in this, there is a vulnerability if we don't get the additional resources. That's right across the piece. So in terms of transforming your care, if we don't get these resources, then the programme won't be able to progress at the pace at which is deemed necessary. And so that will have a detrimental impact moving forward.
We stand then, is this still a 3 to 5 year plan?
The programme is a 3 to 5 year programme, and we would look in terms of how the budget changes over that 5-year period in terms of any scope to progress where there had been a slowing down in the programme. And it's not something that you can sit and easily predict at this point in time because of how resources change.
But you're admitting in that there is a slowing down of the programme?
I'm saying there could be because
but surely
the programme is resource dependent. I mean,
yeah,
we need the resources.
So by implication or inference or fact, the process must be slowed down now because you only got 9.4 over 28 million bid and nothing in January, and now the potential for less than what you want in June.
There's a whole combination of things there in terms of the pace of progress of some elements of implementation were slower than had originally been envisaged, and that would happen in any strategic plan like this. Inevitably, if we don't get the funding that is deemed necessary, and we believe these are realistic assessments of the resources required, inevitably it will impact on the pace of progress.
Yeah, and given the category of not contractually committed, some of those processes within are obviously going slower than others.
Well, if it's not contractually committed, the funding is not currently in place and the commitment's not made legally at this point in time.
So this is slowing up.
It would.
And as we sit today, the whole process is slowed up.
No, I don't. I think it would be wrong of me to say the whole transforming your care process has been slowed up because there has been significant progress across a whole range of areas. But to progress it as intended, we need the funding that's been identified.
Was it possible, Chair, to ask for some sort of indications about what's not moving off the starting line, what's halfway up the starting line, what's
Well, in terms of this bid, part of the 21 million is made up of a number of different elements.
That's not the point of it. I mean, in general, in terms of transforming your care, I mean, it allows to be considered judgments around these things.
Sorry.
There's some information in the pack today around the 99 proposals and progress around those. But I mean, it would seem to me, and I know there's a number of members want in on this as well, that the transition, which I would even suggest maybe the cost of the transition has altered somewhat from the 70 million.
Well, the 70 million was the estimate at the time when transforming your care was
has
published.
It increased?
In overall terms, we don't have an estimate that increases the 70 million, but the profile of it has changed in terms of how it's spread across the years. So that's what's different from the original profile. I'm sorry, I don't have that in front of me, but the profile now is reduced in the first 3 years compared to what the original profile was. But overall, the overall at this stage, the total 70 million over the 3 to 5 year period would still be required.
Okay, I know there's a couple of members had indicated on this issue as well. Roy first, and then Maggie.
Can I just go back to what was said in terms of the original budget? You're saying that these pressures were unforeseen. Was the fact that health service inflation is much higher than ordinary inflation not foreseen several years ago?
Well, I guess in terms of the outplaying of the demand, I would point to the considerable movement within the 13-14 year, and obviously our visits to the committee in September and December, where you're aware that the trusts were experiencing really for the first time significant deficits that couldn't be managed, and that has put us in an unforeseen place up until 13-14. The position of the department was that it could be managed, and that has been shown within our provisional outturn numbers. And unfortunately in 13-14 that was no longer the case. So the demands and the expectations have increased, and I guess combined with that, our ability to take out savings has also become harder and harder and harder, because, as the committee would well be aware, those savings go on 1 year after another. So it's the combination of pressures and savings that drives out the deficit that we currently have, and we haven't put in bids of the 65 million in the order of that in January monitoring, and that was a completely I guess new approach for 13-14.
When I looked at last year's June monitoring round, the total resource bid from all the departments was 179 million, and in fact 80 million was distributed to all Northern Ireland departments. How realistic do you think your bid is to get 160 million from in-year monitoring?
I guess that's predominantly a question for DFP to answer, but there is no doubt there is significant pressure across the block on 14-15, and there will be challenges in terms of dealing with all of those pressures from wherever they come. But the executive will need to consider all of the bids when they go through, which are due with DFP at the latter end of next week. And then consider at that point how those are best managed. But there's no doubt there will be significant pressures on the block in 14-15, and how those get managed will be then considered by the executive later in June.
And if you don't get 160 million, is the health service in crisis?
If we don't get 160 million, I guess the first question is how much would we get, and therefore where does that leave us? What can we do in terms of managing within those resources? The paper on the 14-15 position set out for the committee the types of issues, which are really the only things that the department can do in terms of managing its budget. So if there aren't additional resources from the Assembly, then you're looking at us having to reprioritise, Minister looking at what he can do within the resources that he's got. we still have to achieve the savings plans that we've already assumed we're achieving at the 170 million. So those are assumed to be achieved in order to get to the 160 million deficit. And then you're looking at things about, well, what other impact can there possibly be? Hence why, I guess, in terms of the bids, if you can scale back expenditure like the likes of TYC or elective care, those are the types of things will need to be considered. But the options are, are relatively limited and are difficult to implement. They involve looking at the services that we currently provide. They involve looking to see whether more savings could be identified. So they're all set out there for the committee, and we'll need to reflect on that, after the outcome.
You mentioned pressures on elective care. I noticed of your £30 million bid for elective care, almost half, 14.1 million, was down to orthopaedics. I'm certainly aware from a constituent of someone who's had to wait approximately a year for a hip operation, against an 18-week target from referral to treatment in the rest of the United Kingdom, certainly in England. If you do not get the 14 million for orthopaedics, will it be extending beyond a year for hip replacements?
Taking the hip replacement target, that's but all of the targets are clinically driven, and that's a key target where there is a lot of focus. And there had been significant progress in terms of the hip fracture target over recent months. But obviously, again, in terms of the funding that's required for orthopaedics...
Well, you talk about hip fracture, but it's someone who just needs a hip...
sorry, a hip replacement, right.
Okay.
No, well, there is significant pressure in this area, and as you say, the orthopaedics has made up a significant extent of this bid. If we fail to secure the additional resources here, then that will impact on the waiting list. Now, it's difficult to say the extent of which that would impact, because overall the extent of the gap in elective care is 76,000 assessments and 28,000 treatments. That's the gap that's been identified in terms of demand capacity by the board. All of that, a significant amount of that, or a level of that, will be dealt with by the Health and Social Care Board through use of its own resources. But in actual fact, the funding that's been identified here under this bid would be required to address, out of that backlog, 28,000 assessments and 11,000 treatments. So clearly, if that isn't secured, although the board will be able to make some inroad into some of the waiting lists, this is a significant amount, and waiting lists, they will not be able to deliver on the ministerial targets. And what they will be working to do is to keep as close to that as possible, but they need this funding in order to deliver on the targets.
A final question, if I may, is just how soon after the gin monitoring round will the department be able to determine what action it's taken?
Well, as I understand it, we obviously need the executive decision, obviously, on the gym monitoring round first and foremost, which I think is expected for the latter end of June. And then it will depend on looking at where we are at, the level of resources we've got, and for Minister to consider what happens next. So I guess it will partly depend on how much we get and how challenging or otherwise the position is. Having said that, obviously, the later on you go through a year, the harder that it is for any department to manage its position as you move ahead.
Okay, I know before I had, because I assumed it was in the same issue, but before I bring Kieran in, the other point that somewhat alerts me is, or alarms me even, is we talk about in terms of capital, we talk about the 15.25 million capital that's going to be returned to DFP, and the 10.45 million of that relates to the Royal Children's Hospital and Energy Centre. First of all, I'm asking for clarification on what the Energy Centre is, and second of all, I'm asking specifically why the Children's Hospital project has been delayed, and is the entire project now effectively at risk if money has been returned?
No, I can assure the committee that it's not at risk. This is a timing issue going into the 14-15 year. It is a significant amount of resource, but equally the scale of that project is some £223 million in total. So it's a significant project, and what the 10 million reflects is from the original assumptions of what we could spend within the 14-15 year. Because it's a ring-fence project and deliberately done that way, we aren't able to use those funds into other projects, and therefore the money has to go back to the executive. The Energy Centre is on the Royal site and is effectively to upgrade the energy facilities for the entire Royal site, and that has to happen at a point in time in terms of the expansion on that site and to support the services there. So it's an essential element, effectively, of the redevelopment of the Royal in its entirety. But in terms of your general point and your concern, the slippage on this does not mean to say that that project is in jeopardy, and it remains on schedule to be completed in the same timeframe. It's just going to kick off slightly later than was originally intended, and that's impacting on the 14-15 year.
So what do we mean by slightly later?
It'll be completed by 2021, which was the original intention, is my understanding.
Okay, so the surrendering of the 10.45 million won't you can give absolute assurances to this committee that there will be no, this is about timing, and there will be no delay or risk to the project?
That is our assumption at this point in time as we look at it in the very, very early days of the project. We will give that money back, but we are not expecting any impact on the actual project in itself, and that it would still move ahead. Ultimately, that is a decision for the executive if something different were to happen. But there will still be expenditure within this year, which kicks off the project and gets it off and running. It's just slightly later than was originally intended.
Well, can we seek that information as well in terms of by way of assurances in writing to the committee around the timelines being on schedule, effectively, and that there's no risk?
The end. Yeah.
Okay, and Roy, on this issue,
yeah. As part of the development of the new children's hospital, there was a new scanner which already had been delayed. Is it being further delayed with this announcement of 10 million of capital not being spent?
I don't think that's impacted by this particular proposal. This is I can certainly clarify that.
Okay, thank you. Kieran had indicated next.
Yeah, Chair, thanks very much. You used the term alarmed, and what we've been hearing, in fact we did use the term horrified last week when we got the letter from the department in relation to what we're discussing today, and the deficit, the huge deficit there was. And we're talking about, at this moment in time, we're talking about 14-15. On the last page of that, last week, the 2015-2016 pressures is estimated to increase to over 317 million. So we're talking about a real crisis in the health service as we stand at this moment. And despite your best efforts to try and convince us otherwise, I can see no way out of this. And I heard Catherine's response to someone about the consequences. Again, on that paper, you do say where if sufficient funds cannot be met, access to waiting times will be compromised. And this committee, all of Northern Ireland community, is crying out about waiting times as we stand. And Catherine has confirmed that will be the consequence if we can't get even some of this out of this monitoring round. That's horrendous. That's dreadful.
Just to absolutely clarify that, Kieran. What I'm saying is, given the resources and given the pressure, it's likely. I can't say it will definitely depend on the decisions taken in light of the resources, but clearly there's a pressure, and clearly it's likely to be impacted.
And worse still, Chair, the waiting list is bad enough. The next one is the safety and quality of services provided to patients and clients may be compromised. So you're saying again that patient safety will be compromised if we cannot obtain some of the 160 million that you're looking for?
And that's where patient safety...
That is a crisis, surely.
The patient safety is the key priority in terms of every decision the Minister takes on allocation of funding, and that is, in terms of the position that will be at the outcome of this, patient safety will be at the forefront of any decisions taken.
Yeah, but still, if it's not, that funding is not forthcoming, patient safety will be at risk, will be compromised. And that cannot be acceptable to this committee or to anyone that's trying to provide a first-class service through the National Health.
And certainly, as Catherine says, the Minister has been very clear that the safety and quality of services is paramount in his decision-making. It says it may be compromised, and we have to look, and the Minister will need to look at what resources we get, and therefore where the priorities go. And he will take the safety and quality of care very much to heart within those decisions.
Well, let's hope so. Again, going back to the last, was it the September monitoring round, where you did not get the amount of money you are you expecting something similar here? Are you expecting to get 160 million as requested here to cover all of these?
We have certainly put forward what we believe to be very realistic and yet essential bids effectively into the DFP and executive system. It'll be up to them ultimately to decide what happens, and in doing so they'll be considering our pressures alongside those of other departments. But the bids that we've put forward, we will have to see what comes out of the gym monitoring round and then reflect at that point. But certainly if we don't receive all the resources, it would be very hard to see that the department would be able to sustain all that it's currently doing. In fact, it wouldn't be able to sustain all that it's currently doing without the resources that we have bid for.
Well, I mean, that's shocking in itself. If you can't get this funding, the patients are going to have to wait. Their safety is going to be compromised. I mean, going back to what was talked about earlier, the Transforming Your Care funding, we're still pushing ahead with this, and yet we've no guarantee that the funding. It seems to me that it's a robbing Peter to pay Paul, just to keep somebody from saying we're not in a crisis, and that can't be right.
Well, at the moment we're working through the processes which are set up to identify where we have pressures. Those are being logged through and we wait for that outcome, and then we'll need to see what happens next at that point. But as the paper sets out for you, none of these options are easy in terms of if the money is not found from the centre. The options within the health budget per se to be able to balance this are very, very difficult.
So, in actual fact, Chair, just in conclusion, what we're hearing today is that if this funding isn't forthcoming, our constituents, all of our constituents throughout the length and breadth of Northern Ireland, will be at risk, and we hope, and sincerely hope, that £160 million will be forthcoming. Thank you.
Okay, thank you for that, Kieran. I have Gordon next.
Thanks, Chair, and thanks very much, panel. On the list of priorities, unscheduled care patient flow, 22 million. Under the rationale, it's categorised as an A. Does that mean we're committed towards that, and the money is already in some way spent or certainly committed? And does that include the ongoing issues at the Royal, for example, in trying to address them? Is that included in that programme?
If I maybe make a start on that and maybe ask Catherine to come in. In terms of the, yes, we've made a bid for 22 million. The committee would be aware that there certainly have been unscheduled care pressures, and in fact we bid for some £11 million in January monitoring last year. So there are significant pressures in there, and that reflects the need to effectively sustain the demands that are in there, emergency admissions having increased, and equally then looking at ensuring that patient flow is maintained across the entire hospital system and indeed out into community care. So the pressures that are on there is about dealing with the people who are presenting within ED, but it's also about looking about the wider system and whether resources can go into both the hospital side and the community side to address that unscheduled care.
The fact that it is categorised as inescapable, that money has to be found. That money needs to be put in place to try and address this issue that we hear so much about. It is a priority day in and day out. Every week it's in the media, and we're all sick, sore and tired of it. And I think it needs to be addressed, and we need to get to the bottom of it.
And you're absolutely right. It is a critical issue and it needs to be addressed. And the unscheduled care bid is made up of a number of elements. And if you look at those different elements, it is that whole systems approach. in looking at bringing in additional staff in areas into the emergency department, medical admissions unit. This is about ensuring better flow of staff or better flow of patients. Elements of the bid are in relation to 24/7 or 7-day lab services to ensure that systems don't slow down over the weekend, that the system continues to operate 7 days a week. And another part of this bid is £11 million for winter pressures, and that's about effective planning, about saying at this stage we know that this funding is needed, the various elements, to ensure the system works effectively, that there's clear patient flows, that there are no blockages in the system, and recognising, based on historical trends, that over the winter months there will be severe pressures on the system, and to plan for those now. So that's the totality of the unscheduled care bid.
On the winter pressures, sure, the winter pressures come up annually, so why are they coming in under an additional bid?
Well, the non-recurrent fund, it's required to manage the increased demand during the winter months, and that's based on the latest assessment that's over and above what would be available in the budget that was agreed, and also to address pressures which have been unforeseen in unscheduled care due to increased emergency admissions. And I don't have the statistics here, but we can see there's a clear increase in the number of admissions and attendances at emergency departments.
So just to recap, then, this 22 million, if we're speaking to our colleagues, we need to emphasise the need for that funding to be pushed through, because
yes.
Try and address this recurrent problem at A&Es, mainly in the Royal and in the Belfast Trust and the Ulster as well, which is continuously under pressure now. But I think that's important that funding is focused upon. Just moving on to a couple of other issues. Public health, and we hear a lot about it, and I think we're all very supportive of into prevention. Cancer campaigns, ovarian cancer, for example, and the funding that's required there, and others. Is there money going to be earmarked for it within public health? Is that to be part of that 10.5 additional funding?
In terms of campaigns, that, as I understand it, is about looking at, as you say, cancer campaigns in their totality. The bid on public health is focused around a large element around new vaccines, where, for example, the flu vaccine can now is being given to more children. There are also some screening elements within the public health area. This area is led a lot by the JCCVI approach and what they agree, and maybe Liz can talk a wee bit more about
it's more than just promotion. It's more than promotion, is it? A public health bid. Does that include more than promotion? It also includes vaccination.
Yes. It includes a number of sections. There's vaccination programmes at 5.3 million. The National Institute for Health Research, a contribution to that, 1.7. Work on obesity at 0.7, screening services 0.9, addiction services 0.7, and then a selection of smaller initiatives 1.2, making up a total of 10.5. You picked up an important point there about prevention. Prevention is vitally important. It's been said that vaccines and clean water are the two most significant things in terms of public health. By vaccinating people, we can prevent them from getting a disease in the first place. So therefore, if we stop it at that point, we're not having to deal with the infections, with GP attendances, with hospital admissions, critical care, mortality and so on. And the bid includes 3 particular programmes. There's the Children's Flu Programme. You'll be aware this year flu vaccine was extended to all children in 2-year-olds, 3-year-olds and primary 6 children, healthy children, and that was the first time that had been done. In this coming year, that programme will be rolled out further in the second phase, so that we'll be offering vaccine to all children from preschool children from 2 years upwards and all primary school children, and then next year we will be extending that into secondary school. And that is very much on the advice of JCVI. You mentioned earlier about unforeseen expenditure. The last year or 18 months has been a time of intense activity in terms of new vaccination programmes, and we have, I don't ever recall, and people who've worked in vaccine world have not, can't recall a time whenever there have been so many vaccination programmes being introduced, but that's all good news because that is preventing disease occurring. The other programmes, the Meningitis C campaign, we're all aware of the dangers of meningitis C, and that is, the schedule has changed slightly, and we're now introducing a catch-up programme for any young adults aged 18 to 25 who are starting university for the first time in September 2014, and that will protect them at a particularly vulnerable time. There's a high rate of carriage of meningitis, particularly in people at that age, and just the coming together and the close mixing of students, particularly in halls of residence, mean that there is a very marked peak and increase in risk. So we would be offering that vaccine probably to in the region of 12,000 students, and we would expect to see a reduction in risk, certainly for them. And then finally, the shingles programme. You're aware of the severity of shingles, particularly in elderly people, and JCVI had recommended that that programme be extended to people aged 70 to 79 years of age. It has to be done in a phased manner due to certain limitations in the supply of vaccine. Last year we introduced it for those aged 70 and 79, and in this coming year we're extending that to those who are coming 70 this year, and then those who are aged 78 and 79. And we hope that we'll be able to catch up on the cohorts in between times over the next few years. So that is all something that we would very much support because of the prevention and the benefits that can be gained from that. You know.
That's fine. Just finally, on the clinical negligence, we're still looking for £10 million additional funding for that. It's under rationale B, which means it's inescapable, I think, but not fully committed. Is that basically what it says? But is there not? Are we not making progress in relation to this, trying to reduce this problem by introducing new methods, trying to stop recurrence of practices?
Absolutely.
Processes that have been seen to be ineffective, been highlighted and identified as risk areas. What are we doing to try and reduce those risks? What procedures are we putting in place, not only to reduce them but to eliminate them altogether, and trying to cut this down, because this is public money that's been wasted here. Patients are suffering as well, and as a result everyone loses out. So action should be taken to reduce that. We shouldn't be looking for an additional 10 million here. And we should be living with at least within our budget.
You're absolutely right. In terms of clinical negligence, the pressures that we experience today will, in large cases, remain or relate to events that have happened some considerable time ago. There is a considerable time lag between the settlement of the case, which is what is impacting the budget within 14-15, and the actual incident that caused the issue in the first place. So what we do need to do is to ensure that lessons are learned way earlier in the process, and that's part of the incident reporting system and how that works, which is all about ensuring that lessons are learned. The Quality 2020 strategy is equally about ensuring that care is taken about the quality of services, and that there is an understanding early on as to what caused a particular difficulty, and that lesson is learned and then shared across other trusts as necessary. Because it's only through doing that in 4, 5, 6 years' time you can minimise the clinical negligence settlements coming through. It's a challenge across everywhere, in that as the opportunities to treat people increase and the amount of things that you can do increases, that equally can bring with it an element of risk as well. So I don't think it would be right to say that we can ever eliminate clinical negligence. That will not happen. But equally, what we do need to do is ensure that the lessons are being learnt. And there certainly has been a lot of focus on this in recent times about trying to ensure that that actually happens. But the impact of that, or the effect of that, won't be until some further years down the line, just because of the timeline it takes to deal with them. We're also looking at whether there are other ways of dealing with clinical negligence settlements as opposed to actually getting to that point in the first place, and that can be looking at how complaints are managed. It can be looking at whether mediation would help, whether alternative dispute resolution procedures would help. So all of that in terms of how do you avoid getting to the space of clinical negligence in the first place, as well as learning the lessons as to what caused it in the first place, are all part of the agenda moving forward, because we do need to try and manage the spend in this area so we can put more resources into frontline care.
Okay, folks, thanks very much. Thanks, Chair.
Mickey?
Yeah, it was just a comment, really. The RCN gave us a presentation a few weeks ago, GYC, and their comment was it's a vision without action. And I think what they did today is kind of reinforced that, because it seems to me that the cart is firmly in front of the horse, the cart being the strategy, the horse being the horse at the moment struggling greatly to catch up with the cart. The cart seems to be moving downhill at a very fast pace. The horse simply isn't keeping up with it. So it seems strange that you have a strategy that hasn't been properly worked out in terms of money. Gordon made the point about the winter pressures. I mean, that's recurring. I've heard that since 2007. So it just seems that, hindsight's great, but foresight's even better. And it seems to me there should be a bit more foresight applied, and it seems that that's simply not happening, because transforming your care seems to be running into more obstacles than anything else that has been put forward in the past number of years. Because if you haven't got the money, how can you possibly implement it? And if that wasn't planned for, then you're just playing catch up all the time.
Maybe if I could pick up on that, there is 70 million transition costs required, and that was clear. But that's not the whole of transforming your care. There is a lot of action being taken forward. There on various strands of this, and it's right across all trusts. A key element of transforming your care was the establishment of the 17 integrated care partnerships, which are up and running and which are beginning to produce work in terms of identifying better care pathways, addressing frail elder needs. Now, by its nature, it's going to take some time and to actually see the outcome of that, and then to evaluate the effectiveness. So it was never a case that this was going to deliver extremely quickly. The more progress is made as early as possible, the better, because transforming your care made very clearly the case that in terms of all of the things that we're seeing impacting right across the budget, the demographic change, the long-term conditions, the ageing population, all of that means we need to make the changes into delivery of health and care services that are envisaged within transforming your care. So although there are elements of this that we don't get funding will impact on that, there are huge elements of the programme that are still moving forward across all of a huge number of the 99 proposals. I just think it's important that we don't convey that this is the entirety of TYC, but that a number of strands of work are continuing. But equally, to do TYC as was envisaged in the report, the funding is required.
But I'd say, just with respect, in terms of the 17 centres, the one in my constituency is certainly not moving forward that quickly. I think in terms of the privatisation of those centres, I think it would be very difficult to dissuade people from the notion that not only is transforming your care supposedly a shift left, but very much a shift towards privatisation. I think you're going to have a very difficult job persuading people otherwise, perfectly honest. So maybe I'll leave it at that. Thank you.
Okay. Well, can I thank you? I think the very clear message coming from this is clarification as to particularly the Transforming Your Care transitional funding. It doesn't provide an awful lot of logic to me that issues like the bid for public health, which are all desirable projects around vaccinations, etc., and are certainly, in terms of early intervention and prevention, have huge merit. However, it doesn't tally up to me that a bid for that type of work, as desirable as it would be a higher priority than the transitional funding that's required for the entire strategic framework for the new delivery of health. So, what I'm suggesting that we seek, and I think you've heard it clearly from a number of members today, is an explanation as to why that bid would be categorised as C, and an explanation or assurance going forward that, as a result of that being classified as a C, that it doesn't put the entire framework at risk. I think we need to get a sense of that in writing from yourselves as to a risk assessment to the fact that, as we move on, we only have 28 million in the system in terms of what was a 70 million bid, and where the risk assessment is in terms of the system. Equally, I think we need to seek the assurance around the Children's Hospital.
Happy to come back to the
And
committee.
we need to get a sense that, if I'm listening carefully to what you're saying, but ultimately there's 10.4 million being returned in the system, and the implications of that on timescales or any potential risk to the project. And we know that you're on a timeline. I think that this bid has to be with DFP by the 5th of June.
5th of June to DFP.
So we would
yes.
appreciate a response ASAP on those issues going forward.
Okay.
So thank you for your time today. Members, moving on to item 6, which is evidence session on the proposed Adoption and Children's Bill. There is a briefing paper from the Department at page 3 of the table papers. I want to also refer members to the Hansard and briefing papers, which relate to the Department's evidence session on the bill on the 16th of November 2011, which are at page 102. And it's important, I think, to point out that the committee has not taken any evidence on this proposed bill since that time, so there's been considerable time lapse. I want to advise members also that the Department has not yet obtained executive approval to go out to public consultation on the proposals for the draft bill. So members today may just want to ascertain what exactly the Department's policy intentions are with regard to the bill. It is a complex bill, and depending on the issues that arise today, I think that we may need further briefings from the Department before being able to come to a view as a committee on whether we are content with the policy proposals. I think we're just waiting on our guests. Okay, folks, you're very welcome. We have Mrs. Eilish McDaniel, Director of Family and Children's Policy, Mrs. Julie Stevenson, Head of Adoption and Children's Bill Team, Mrs. Frances Nicholson, Social Services Officer, Office of Social Services, and we have Mrs. Caroline Picton-Linnis, who is the Deputy Principal of the Adoption and Children's Bill Team. So you're very welcome, folks, and we will hand over to yourselves for a 10-minute presentation, then open it up to members for queries or comments. Okay. I'm not sure, is it Eilish yourself taking it?
Chair, yeah. Good afternoon. I would like to thank the committee for the opportunity to provide an updated briefing in respect of the Adoption and Children Bill. The Department was last invited to brief committee members on the bill in November 2011. As indicated previously, the bill is principally intended to modernise the legal framework for adoption in Northern Ireland and place children's welfare at the centre of the adoption decision-making process. The bill will deliver a framework for adoption which is more consistent with the principles and provisions of the Children Northern Ireland Order 1995 and international human rights requirements. It will create greater opportunities for older children to benefit from permanence and stability by offering them an alternative route to permanence through the introduction of a new special guardianship order. It will reduce drift and delay for young people who are unable to live at home by introducing a principle of no delay and court timetabling, and will also provide for better quality, consistent and efficient services for everybody affected by adoption. The overall timeline for the bill is particularly challenging. Subject to executive approval, the Department intends to consult on the draft bill from July to September 2014. The Department fully accepts that it is not ideal in any way to consult over the summer period. However, we have extremely limited capacity to extend or amend this period. The bill must be introduced in the Assembly by early March 2015 at the latest to enable the bill to obtain royal assent by March 2016. The substance of the bill relates to adoption, although we are also proposing to make changes to the Children Order. The bill will contain approximately 140 clauses and 5 schedules. It is complex in nature and will contain a range of prescribing powers. The bill cuts across the policy responsibilities of a number of departments. For example, it will place certain requirements on the Registrar-General in respect of the continued maintenance of the Adopted Children's Register and the Adoption Contact Register, and access to information by adopted adults. Some provisions impact on private law, for example, the introduction of the Special Guardianship Order, and both are the responsibility of DFP. It will require consequential amendment to legislation which is the responsibility of other departments, for example, DEL and DSD, in relation to the legislation governing statutory adoption pay. It will introduce new offences relating to adoption, for example, offences associated with the removal of children from prospective adopters and the disclosure of protected information linked to adoption. It will introduce new court orders, potentially impacting on the legal aid budget, and both require the support of and liaison with the Department of Justice. Work on the consultation document is being finalised. The document includes 4 chapters. Chapter 1 relates to the contents of the bill. Chapter 2 to the legislative changes which have occurred in other parts of the UK and the Republic of Ireland since the introduction of the Adoption of Children Act 2002, with which the Adoption of Children Bill closely aligns. Chapter 3 relates to new policy proposals to be considered for inclusion in the bill, and 4 outlines the arrangements for consultation. The majority of what is contained in the bill is based on policy proposals which we originally consulted on in 2006. It also contains new provision not previously consulted on, but which we consider will make a step change for children and young people and deliver improved outcomes for them. In the consultation document, we are also seeking views on provision which is a departure from policy previously consulted on in 2006. In the briefing paper provided to members in advance of today's sessions, and I have to offer my apologies for getting this paper to you late in the day, but in that paper we set out the key provisions contained within the bill, both in terms of adoption and children more generally. I'm not intending to describe these in any detail in my opening remarks, but will answer any questions on any provision contained in the bill which members may have. With the committee's agreement, I will focus on what is new and what is a departure or a potential departure from original policy. Provisions which have been included in the draft bill and not previously consulted on are amending the Children Order to enable a trust to provide accommodation for respite purposes to a disabled child with the consent of his or her parents without requiring the child to become looked after. That is taken into care by the Trust, as is currently the case. Amending the Children Order to lift the restriction on making of cash payments to families in need in exceptional circumstances only. Creating an additional duty on trusts as part of the duty to safeguard and promote the welfare of a looked-after child, to promote the child's educational achievement. Strengthening further the arrangements for contact and introducing 2 new post-adoption contact orders, a contact order which will require the adoptive parent to allow the child to visit or stay with the person named in the order, or otherwise have contact with them, and a no-contact order, which will prohibit the person named in the order from having contact with the child. We'll also amend the Children Order to enable guardians ad litem appointed by the courts to represent children in family law proceedings to be directly employed by NAGALA, reflecting current employment practice within the special agency. We'll introduce a power for the Department to regulate the operation of fostering panels in Northern Ireland by prescribing, again by way of regulations, the Constitution and the membership of fostering panels, their functions and how panel meetings should be conducted. We'll introduce an independent review mechanism to enable reviews of decisions by fostering panels, and the mechanism will be comparable to the independent review mechanism for adoption decision-making, which is referred to in the briefing paper. Changes in policy position relate to a number of areas, and they include independent reviewing officers, adoption support agencies and adoption support advisors, adoption support services and special guardianship orders. Starting with the independent reviewing officer, the primary focus of the role of the officer is to quality assure the care planning process for each child, participate in any reviews of a child's case and ensure that a child's current wishes and feelings are given full consideration. In England and Wales, IROs are also responsible for monitoring the local authority's performance of its functions in relation to the child's case. In recent years, a number of systems and mechanisms for independent review of HSE services have become well established in Northern Ireland. Also, significant investment has been made in advocacy for children in the care of health and social care trusts. Advocacy services which, under the bill, will be given a statutory basis. In addition, the operation of the IRO service in England and Wales has met with some criticism. And in light of this, the Department is seeking views on whether an IRO service should be put in place here under the bill, or whether a non-statutory system of independent review, similar to that now successfully in operation in Scotland, should be introduced. Also in England and Wales, adoption support agencies provide assistance to adopted children and adults, such as counselling and finding out the details of their adoption. They also help adopted children and adults and their relatives if they want to know more about or want to trace their birth relatives. Most people who use adoption support agencies in England and Wales are adults. The role of the adoption support advisor in England is to provide advice and information to people affected by adoption on adoption support services. They also advise staff in adoption agencies on assessment of need for adoption support, on effective planning for service delivery, and in particular supporting and facilitating intra-agency working when it's required. We don't intend to include within the bill provision for the establishment of adoption support agencies or adoption support advisors. In relation to support agencies, we do not consider that the volume of adoptions in Northern Ireland in any given year is sufficient to justify the establishment of a distinctive, dedicated support agency. Also, adoption support agencies are already well developed in Northern Ireland and are already included in the services provided for by our existing adoption agencies, both trusts and voluntary adoption agencies. In relation to adoption support advisors, again, it is not considered necessary to establish a distinct role, principally on the ground that it will be difficult to justify because of the number of adoptions in Northern Ireland each year. However, we will ensure that adoption support services involve the supply of advice to those affected by adoption. In other words, we will reflect the role and the function of the adoption support advisor without creating a distinct role in statute. The bill places a duty on adoption authorities to make arrangements for the provision of adoption support services, as specified in regulations. It also provides a new right for those named individuals to request and receive an assessment of needs for adoption support services. However, as currently drafted, the bill does not require adoption authorities to provide support services where these have been assessed as needed. Rather, authorities must decide whether to provide the services, and this mirrors arrangements in England and Wales. In Scotland, however, the authority must provide the service which has been assessed as needed in respect of certain people, those adopted, those who may be adopted, adoptive parents and prospective adopters and birth families. In all other cases, the authority has discretion whether to provide the service which has been assessed as needed. In the consultation paper, the Department is seeking views on whether we should create a duty to assess only, or whether we should also create a duty to provide services assessed as needed. If the latter, we are also seeking views on whether such a duty should apply in respect of all individuals or be restricted to particular categories of people, as currently happens in Scotland. The bill as drafted mirrors the special guardianship order arrangements currently in operation in England and Wales. However, a number of issues have arisen as part of the implementation of those arrangements, and we now have the opportunity to introduce additional provision to prevent similar issues arising in Northern Ireland. Proposals on which we are seeking views in the consultation document will include whether to impose additional requirements to ensure that special guardianship orders are not made until placements are tried and tested, whether to introduce panel consideration of SGO applications relating to looked after children, whether to specify in regulations that for looked after children and their special guardian, an authority must carry out an assessment of need for support services and for the support plan to be subject to the approval of the SGO panel as part of its considerations. Finally, we are also seeking views on a range of proposals neither previously consulted on nor included in the bill. They are contained in Chapter 3 of the consultation document, and in brief we are seeking views on whether to introduce a duty on the Health and Social Care Board to provide information about adoption support services, to repeal Articles 74 to 78A of the Children Order, which deal with the provision of accommodation for children by voluntary organisations without being looked after by a Health and Social Care Trust, on the basis that such practice ceased some decades ago. Introduce a right for descendants of adopted people to access records and intermediary services. Amend the Children Order in line with the Children Act to strengthen arrangements in respect of private fostering. Require a Health and Social Care Trust to consider placing a child with duly approved carers when considering adoption, or a decision has already been made that a child should be placed for adoption. Introduce a power to provide, by way of regulations, for the search and inspection of the adoption regional information system by prospective adopters who are suitable to adopt a child, to enable them to identify a child on the register for whom they might be appropriate adopters. And finally, the intention is to change the name of those independently representing the interests of children in court under Article 60 of the Children Order from the Latin term guardian ad litem to Children's Court guardian, and that was the subject of a recent consultation by NAGALA. Members are aware that there has been a legal challenge of current adoption legislation brought by the Northern Ireland Human Rights Commission. The legal proceedings concluded in October 2013, and as a consequence, the draft bill contains provisions that reflect the High Court judgment and the Court of Appeal ruling in respect of who can apply to adopt. Executive approval to commence the process of drafting the bill was secured on the basis that the draft bill would reflect the outcome of the judicial review proceedings. I would like to thank members for giving me the time to provide an overview of what we plan to do in terms of consultation on the draft Adoption and Children Bill, and we will of course share a copy of the consultation document with members in advance of its publication. I'm happy with my colleagues to answer any questions that members may have. Thank you very much.
Okay, thank you, Eilish, for that. Just maybe firstly, the paper talks about, makes reference to amending the eligibility criteria to enable one person or two people living as partners in what's called, I think here, an enduring family relationship to apply to adopt. And I'm just wondering, how is enduring family relationship defined?
It's not defined within the bill, Chair, but it's certainly something that we would have to consider for inclusion in guidance. And it is actually a term that is used quite frequently to describe a suitable household for a child or children to be brought up in. But in response to your question, nothing in the bill to define it, but certainly it is something that we would need to define very clearly or describe very clearly in any guidance document that accompanies the introduction of the...
And is that likely then to cover couples in same-sex relationships, and whether they're in civil partnership or not?
the emphasis is on being able to offer a child a stable family home, demonstrated by being in a stable family relationship. So it is, if the question is it confined to married couples, for example? The answer to the question is no, it will extend to other couples.
But that is something that will be very clearly laid out within the guidance?
It would have to be laid out within the guidance, and in response to the judicial review findings and the findings of the appeal court in particular, which I think happened in June 2013, the Department issued a note to adoption agencies, that's trusts and voluntary adoption agencies, instructing them to accept applications from same-sex couples and unmarried heterosexual couples.
Okay. And on another point, I know it's noted in your briefing paper about amending aspects of the children's order, and it seems to be in and around greater permanence for young people, and particular family situations, I suppose, for want of another description. But in terms of maybe some of the criticism that is reflected on the children's order generally, that it is dated, that it's out of date, and some of the challenges along the pending mental capacity bill going forward, that ultimately under 16s are left out of that legislation and will be still subject to a children's order, which many would say is outdated in terms of the needs of children in our current climate. Is it enough? Is it enough to simply say that we will amend or tag on, or?
It was always intended, the reference to amending the children order to offer another route to permanence is a direct reference to the introduction of the special guardianship order, and that is something that we consulted on back in 2006. And we're making further amendments to the children order, are proposing to make further amendments to the children order based on changes that have been made in other parts of the UK over the course of the last decade. So while we're consulting on a set of proposals that were originally consulted on back in 2006, we have spent a bit of time looking at further changes to children's legislation that have been made to the Children Act, for example, which is the equivalent of the Children Order for England and Wales, and equivalent Scottish legislation. We've either included some changes in the bill, or we have made reference to those changes in the consultation paper. Specifically on some issues, we're seeking views about whether or not we should use the bill to make those changes now. And we've got a catch-all at the end of the consultation document that is basically saying, is there anything else that has happened in legislative terms in other parts of the UK over the course of the last decade that you think have application in Northern Ireland and potentially could be carried forward by way of the bill? You're quite right, the Children Order it dates back to 1995. I think the Minister is on record as being committed to a wider review of the Children Order. We had two options here. We had to move now to reform adoption, which is based on practice dating back now, I think, 40 years, or wait for a wider review of the Children Order. Now, the Minister has sided on going forward with new adoption legislation with some children's amendments added to that, followed by a wider review of the Children Order to come next.
Okay. And just finally, another point that strikes me, in terms of kinship care arrangements, how will the bill start to address some of those? Because there's very clearly almost a sense, if not a real sense, of a disparity in services depending on whether the kinship arrangements are formalised or not formalised in terms of access to services. Will it deal with, will the bill address, just given, I suppose I'm saying, that given the high numbers of kinship arrangements that exist here in the north and probably across the island?
You're quite right. The number of children in kinship care is increasing year on year. There's some provision within the bill that I think will benefit children in what we have termed in the recent past formal kinship care. That's children who are the subject of care orders or are in care with the approval of a Health and Social Care Trust. So, by way of example, the intention is to amend Article 18 of the Children Order, which currently only allows for cash payments to be made in exceptional circumstances. The intention is to remove the restriction of payments being made in exceptional circumstances only. That will give a trust discretion to provide for kinship carers, not only kinship carers looking after children in the care of the state, but potentially to the children of families in need. And that strays into what we've now termed as informal kinship care.
Okay, thank you for that. Mickey had indicated.
Yeah, thanks. You've already answered one of the questions. Chair must have been reading mine, because it was about the issue around the mental health capacity, or mental capacity bill, because that's going to be a huge, complex piece of legislation. I think you mentioned in this bill it's going to be 140 clauses, 5 schedules, again a huge bill of complexities. And it was around that for the under 16 in terms of the Children's Order, which the Minister, as you say, has committed to review, but God knows when that's going to be. So it's
it is unlikely to be in the current mandate. A review of the Children's Order, I think, is a big undertaking.
It is a big
Probably
undertaking.
take several years to complete, and then you've got legislative change.
But I think it's
potentially to come
accepted that
behind
it is idea, but you sort of answered that question. But under the proposed amendments, I think, to the Children's Order, one of the things is providing for advocacy services for looked after children, former looked after children, special guardianship children, or adopted children who wish to make representations to complaints. Do you envisage that that would be an independent advocacy service?
It will be. I mean, currently advocacy services, and they're non-statutory in nature, are offered by organisations like the Voice of Young People in Care, and completely independent of Health and Social Care trusts.
The Children's Law Centre and presumably organisations.
Absolutely. They advocacy of its nature, I think, requires an element of independence. And certainly that would be the intention under the new statutory arrangements, to have independence built into it.
Just to point out that presumably complaints and that would go through official channels in terms of social services first. You know, presumably if an adopted child had a complaint and there was a social worker involved, because it's still of a duty of care to the younger children, certainly presumably that would go through those channels before it reached. Or is that maybe
the advocacy services that will be provided relate to advocacy on behalf of a child who has a complaint, for example, and to make about how a trust is performing any of its functions, on any of its functions, some of its functions under the Children Order. So you're quite right. There will be social services involvement there, and then the independent advocate will come in on top of that. Yeah,
that's fine. Thanks very much.
Okay, Kieran.
Yeah, Chair, just very briefly, does this bill, does it merely place us in line with what's going on across the water in other jurisdictions?
It certainly brings Northern Ireland adoption legislation into line with what has happened in other parts of the UK. But I've given you some examples of where we're proposing to go possibly a step further, and one of the examples was a duty to assess whether or not those affected by adoption have needs for services. Our intention is possibly to take that a step further, to say you assess, having assessed a need, then you provide. So in some cases we're proposing to, subject to the outcome of consultation of course, to go a bit further than what's been done in other parts of the UK.
Right, that's just what I wanted to find out. Thanks, Chair.
Okay, Roy.
Again, thank you for your presentation. One of the criticisms of the current adoption in Northern Ireland is the length of time that it takes to complete the process. How do you foresee the average adoption time changing as a result of this new legislation?
You're quite right. The statistics on the length of time taken to adopt are poor. certainly poor in comparison to what happens in other parts of the UK. Currently, for example, from the last entry into care until a child is adopted takes 3 years and 5 months in Northern Ireland, in comparison to 2 years and 7 months in other parts of the UK. We currently have a target to reduce that to 3 years, and that's a target contained within the commissioning plan direction to the Health and Social Care Board. But by way of the bill, or by way of introduction of the bill, which will have a statutory principle of no delay, for example, and will require courts to introduce systems of timetabling by removing a free-in order to replace it with a placement order, altering arrangements for contact, for consent. The intention in doing all of those things as a package of measure is to begin to impact on the length of time that it actually takes a child to be adopted in Northern Ireland, which none of us would accept is acceptable as it currently stands.
And by how much do you think it will shorten that period?
Well, if everything goes according to plan, and on the assumption that the reduction in other parts of the UK is as a result of new legislation, for example, we should begin to be showing durations similar to other parts of the UK, which should make a significant difference for children.
Thank you.
Okay. Okay, can I thank you all for that information? Obviously, this is at very early stages, so we look forward to it being brought forward to the Executive, I think, in the first instance, and continuing to have the consultation around what is a hugely important but probably quite complex piece of legislation. So thank you for your time today.
Thank you very much.
Thank you. Members, just moving on, but probably on the back of this particular session, is there any further actions that the committee wishes to take at this stage, or are we content that the next stage is to go to the Executive, and that we'll get us a sense of that as it rolls on? Or is there anything specific? Are members content that we follow through that process? Okay, thank you.
Right.
Members, item 7 is the proposed statutory rule, which is the optical charges and payments amendment regulations. It's on page 133. The purpose of the rule is to amend the value of optical vouchers issued to certain patients to help towards the cost of glasses or contact lenses. Are members content for the department to proceed with the statutory rule?
Right.
Thank you. Item 8, the forward work programme. I'm asking members to note the forward work programme, which is on page 143. Item 9 is matters arising. Items 9.1 and 9.2 on pages 146 and 147 are correspondence from the Minister about the mental capacity bill. I know this was raised at the start of the meeting today. The Minister has provided an embargoed copy of the draft consultation document and the draft bill relating to the civil population. The consultation was launched yesterday and will close on the 2nd of September. As members will be aware, a joint ad hoc committee comprised of members of Health and Justice committees will be formed to scrutinise the bill. The intention is that the ad hoc committee would be set up once the two departments have analysed the responses to the consultation. So I'm suggesting, members, that the committee writes to the department to ask when it's aiming to have completed the analysis of the consultation responses and when it will be in a position to brief the ad hoc committee on this. Members content we proceed as that? Yep. Page 380 is a response from the Minister providing an update on proposals contained in Transforming Your Care. We have continuously asked the Minister if there's an outcomes framework attached to TYC. He is now referring in this response that there's a benefits management approach being taken. A paper is provided on this approach on page 382, and the Clerk has asked the Department whether this paper has been previously published or whether it was only produced in response to the letter by the Committee in April. The Department has advised that it is a summary of information contained in a number of health and social care documents previously published including the TYC strategic business case, TYC project initiation document 2012 and the delivery strategy document. The Health and Social Care Board has also held an outcomes workshop in June 2013, and this informed the revised TYC programme initiation document, which was produced in March 2014. So there would, members, seem to have been a lot of work going on in the background recently in terms of developing some sort of outcome document, which the Minister is now only making the committee aware of. The Minister has also provided an update against the 99 proposals within TYC. Advising members that the committee is holding a strategic planning meeting on the 25th of June from 12:30 to 1:30 to discuss our work priorities for September. I would suggest we discuss what approach we take to the scrutiny of TYC in detail at that meeting. So I'm suggesting that that is the way forward, unless members have any views at this point. If they're comfortable, yes.
I'm happy enough to go along with that, but I'm just wondering, in view of the importance of what we're talking about, and particularly what we discussed today, would there be any merit in having someone come to the committee to work our way through it?
Well, I think what we're suggesting, in light of particularly the budgetary issues, is that we would seek representation from the department specifically on that. I think then it's for the committee to decide what part, or TYC in its entirety, what role the committee can have. So I would suggest that we do that piece of work on the 25th and then inform the department and seek the evidence from the department or whoever is required at that point.
That's fair enough, thanks.
I am also asking members to note items 9.4 and 9.5, which are on pages 441 and 442. 443 is a response from the Minister to the committee's recommendation, again, that a central register of people with a learning disability is set up. The Minister has restated that he does not believe that a register would be an efficient way to gather information on the health needs of people with a learning disability. He believes that the best way forward is to focus on the GP annual health checks for people with a learning disability. I think the committee has made the point to this department, and it's something that we may need to come back to at a later date if other evidence emerges. I think one of the issues for ourselves was that the GP health checks weren't being fully taken up because ultimately there wasn't a central register of people with learning disabilities. But I'll be guided by members on how we proceed. If we're happy to come back to this, if we want to restate the committee's view to the Minister and the Department, we can do so also.
Chair, just to say, I mean, I'm not at all happy with the response, but we have, the committee has done what we think the right way to go about it, and we're not getting any further. And just keep it under control, under observation, and see how we'll go from there.
Okay. Thank you for that, Kieran. Item 9.7 on 445 is a response from the Minister about laboratory services and workforce planning for clinical scientists. Our members content to note and copy the response to the Association of Clinical Biochemistry, who had raised the matter.
Great.
446 is a response from the Minister about the diagnosis of vasculitis. Our members again content to note and copy this to Vasculitis Ireland, who had raised the matter with us. 447 is a response from the Minister about the establishment of a Cancer Drugs Fund. Our members content to note and copy the response to Cancer Focus, who raised this matter. 448 again is a response from the Minister about sources of guidance for childcare providers. Again, I'm asking our members content to note and copy the response to the Primrose Hill Nursery, who had raised the matter. And 449 is a response providing an update on the development of a neonatal strategy. The Minister states that this is included in the current review of paediatric services, so are we content to note and copy this to Tiny Life, who raised this issue with us. Asking members, therefore, to note item 9.12 on page 451. Item 10 is correspondence, noting 10.1 to 10.5 on 453 to 467. Item 469 is correspondence from 1-to-1 midwives. seeking a meeting with the committee. I'm suggesting that the committee writes back to the organisation to explain that we don't have the responsibility for commissioning services and that we would advise them to contact the HSC board.
Right.
Thank you. And item 10.7 on 471 is an invitation from Parent and NI to visit and hold a committee meeting at its headquarters in Belfast. I'm suggesting that we accept the invitation and that it's factored into our work programme at some point in the next session.
Support you.
Okay, 472 is correspondence from the Association of Social Workers asking to present the report called Blueprint for Change to the committee. Suggesting we invite the group to the next stakeholder event.
Right.
Item 473 is correspondence from BMA seeking a meeting with the committee. Again, I'm suggesting that we invite the group to the next stakeholder event.
Great.
And noting 10.10 on 474. On 475 is correspondence from a Dr McFadden, a social worker, asking to present her research on social work, burnout and resilience. Suggesting members content to invite Dr McFadden to the next stakeholder event, perhaps even as part of the Association of Social Workers delegation.
Great, yeah.
Page 515 is from a former employee of the Health Service. There are details in the letter which relate to a personal employment case. These are not a matter for the committee, and I think it's prudent not to mention the correspondent's name in open session, as she has requested. However, the correspondent is asking whether there is a mechanism for her to contribute to the review of governance arrangements in the HSC being carried out by Sir Liam Donaldson. I would suggest, members, that the committee writes to the department to ask how current and former staff can contribute their views to the review.
And submit this letter.
No, because she's written to us as a committee and asked us for confidentiality, so I think we have to seek from the department how current and former staff can contribute their views, and then we can supply that information.
Okay.
Thank you. 518 and 520 are concerning personal cases. Our members therefore content to refer the correspondence to constituency representatives for support.
Right.
Yeah, great, Mr. Chair, but the one that I would have enormous sympathy was 518, which we've all got, is something that, well, if we could do anything, we would, but in this instance it's one of these individual constituency requests, and I don't know, I would certainly like to, I'm sure the committee would agree, to record our absolute sympathy with what we've had in front of us.
Okay, I think that's fair enough. And again, I think it's it's within the gift of any MLA to engage on any particular issue. But I think that's the appropriate way to proceed on it.
Yeah.
I'm asking members to note 10.15 on page 521. And item 11 is any other business. Do members have any other business? And I take that as no. Item 12, the next committee meeting will be on Wednesday the 5th of June, starting at 2 p.m. in the Senate chamber here in Parliament. Thank you.
Recorded an apology, is that?